gentlemen, welcome to day 3 of Challenges in Hematology, which includes the best of EHA 2022. Completely under the aegis of Mumbai Hematology Group, we are extremely proud to present this marathon educational web series, completely courtesy our program director, Professor Dr. M.B. Agrawal sir, and teachers of teachers. We request you to take it forward from here.
Good evening.
We will just introduce you, sir.
Okay, all right.
Good evening, friends. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, and the Executive Committee of Mumbai Hematology Group. All our discussants were themselves eminent hematologists, medical oncologists, and new participants for sparing Wednesday evening. Do visit our website, mhgindia.com. It gives you all the information about our past educational event, as well as the future webinars and in-person meetings. Today is day 3 of this, as Manoj described, marathon webinar series of 1 week. Today, our guest speaker is Dr. Maciej Zaucha from Poland. He is MD, PhD, Professor and Head, Department of Hematology and Transplantology, Medical University of University Clinical Center, Poland. And he's going to lecture on Hodgkin lymphoma and update in management. Thank you, and over to him.
Thank you very much for your kind introduction, and thank you very much for the invitation. I will start to share my screen, and I hope that you can see the slides. Can you confirm that the slides are seen?
Yes.
Okay, I'll check if I can. Yeah. So I come back to the first slide. So again, thank you very much for the invitation. I'm myself very much interested in Hodgkin lymphoma. Actually, I was giving a spotlight talk regarding the role of radiation in early stage Hodgkin lymphoma, which is a very hot topic. But I extended the presentation for this meeting to also discuss maybe not so important, but I hope very vivid role of radiation in advanced Hodgkin lymphoma. So my talk would be dedicated to the role of radiation in Hodgkin lymphoma in 2022. These are my disclosures. And before I go into the role of radiation, and I'm sorry if some of these slides are very basic for the audience, but I would like to remind everybody what are the current tools we use for the management of Hodgkin lymphoma, because they will be used also in the decision whether the patient should receive radiation or not. So we are now in the era where PET-CT is a basic tool for staging and response assessment. And we are in the era of response-adapted treatment. And this is, I hope, very true, and nobody will discuss with this. Why PET is so important? If you look at this slide, this is a screen showing how Hodgkin lymphoma should look if we think that only neoplastic cells are vivid in PET-CT. As you remember, Hodgkin lymphoma is a very peculiar peculiar lymphoma in which the tumor is composed of only 5% of neoplastic cells. The other cells are recruited by the neoplastic cells but are normal. So if we think that only neoplastic cells should be seen as vivid in PET-CT, the picture should look like that. Only spots should be visible. But in Hodgkin lymphoma, we do see a clear, like a sun signal in PET-CT, which tells us that surrounding cells, the healthy cells, amplify the signal coming from the neoplastic cells. So if we use effective treatment and if we kill neoplastic cells, the signal is lost. And that's why PET is so good, especially in Hodgkin lymphoma, because of this amplification in the assessment of the response. And we use for this assessment 5-point Deauville scale. I hope that this Deauville scale is very clear for you. Interesting part of that is that before introducing of this Deauville scale, it was not really clear what is positive in terms of the PET, what is negative for Hodgkin lymphoma when we assess the treatment. Here, as you see at the upper row, that at the beginning, people would just use visual assessment and thought that the negative is if we do not see any uptake. But gaining more experience PET-CT, we learn that even some uptake doesn't mean that the patient is doing bad. So that's why Deauville scale was introduced. And we should remember that Deauville scale 1, 2, 3 means that the patient is responding well. Deauville 4, 5, that the response is not good. And especially Deauville 5 tells us that the patient is not responding or is progressing. The other very important issue, which I will be discussing during my lecture, is the concept of metabolic tumor volume. Its PET-CT allow us to calculate how much disease we have. So based on this diagram, we can calculate altogether one by one how much tumor we have. And we can calculate the milliliter of the tumor, calculating metabolic tumor volume in milliliters. So we can say that some patients have, let's say, 100 milliliter of the disease. Some patients have 400 milliliters of the disease. And intuitively, you may assume that the metabolic tumor volume may have a prognostic significance. So having said that, we can also, I would like also to remind you that there are some preliminary information that metabolic tumor volume indeed has a prognostic value, because as you see here from a paper published some years ago, which analyzed the patients from a prospective trial in which a standard arm was analyzed in terms of the metabolic tumor volume, in which patients with early stage Hodgkin lymphoma were treated with combined modalities, so chemotherapy and radiotherapy. So the patients who have high metabolic tumor volume and have positive interim PET assessment, these patients were not doing well, whereas the patients with low metabolic tumor volume and negative interim PET, they were doing very, very well. So metabolic tumor volume could be a tool which can we use in the assessment of prognosis, especially for early stage Hodgkin lymphoma patients. So let's go to the radiotherapy. And before I tell more about it, I just would like to remind everybody a very old picture from a very old paper showing that radiotherapy was very important for the treatment of Hodgkin disease, because at that time it was not a Hodgkin lymphoma, it was a Hodgkin disease. And as you see in the upper part of this graph, patients with localized disease could be cured with radiotherapy alone. And that was a very big progress in the treatment of the disease, which was fatal at the beginning of the 20th century. So, but are we afraid of radiotherapy? Yes, we are, since as you see here, when we introduce radiotherapy for treatment, of course, it kills neoplastic cells, but it has not only short-term complications related to the DNA damage, related to the activation of immune system, but we also do see a late complications, really after years after finishing of radiotherapy, related to two major issues. First is the issue of cardiovascular events, and this is a real problem for patients who are treated and receive radiotherapy for example, heart, for the mediastinal tumors. And in addition to that, solid tumors, which are the complication of radiotherapy. So yes, we are afraid of radiotherapy, despite of the fact that it's a very effective tool in treatment of Hodgkin lymphoma. So it's a so effective tool that I would compare this to a hammer sledge, that we can really kill neoplastic cells with this hammer. But with each tool, really an issue lies how to use this hammer properly, and that is the subject of my talk. So let's start with, I would say, an easier part, which is advanced Hodgkin lymphoma. Why it's easier? Because we know more now how to use radiotherapy, and there's no so much controversies related to the usage of radiotherapy for advanced Hodgkin lymphoma. But I will start also with some history. Papers published in late 90s, beginning 2000, showed that addition of consolidative radiotherapy improved the outcome of Hodgkin lymphoma patients with advanced Hodgkin lymphoma patients. A prospective study, very important one, published 11 years ago, showed that if we use radiotherapy, involved field radiotherapy, which was recommended for incomplete response. Remember that at that time, only CT was used for a response assessment. So we didn't have a metabolic tools. We just had the CT, and we use this old-fashioned, I would say old-fashioned tools for assessment of the response. So if there was not complete response, or if there was a bulk disease at the beginning, and I hope that everybody knows what is a bulk disease at the time of diagnosis, I would remind you that the current definition keeps at least 10 centimeters. Some people say 7, but most would agree that 10 centimeters is in the longest diameter. This is a bulky disease, and in most patients, this bulky disease localized in the mediastinum. So in this paper, clearly shows that patients who receive radiotherapy have a better outcome related not only to progression-free survival, that's a 15% difference, but also in overall survival. However, at that time, it was a consensus and suggestion from this paper that despite the fact that radiotherapy consolidation treatment significantly contributes to the cure rate for advanced Hodgkin lymphoma, however, the selection of these patients would require better definition and better selection in prospective trials. But at that time, that was not era of PET-CT. So when we moved to the era of PET-CT, this problem was addressed again, and it was not addressed as its own, but it was fortunately addressed in some big studies. And the one, I would say, most important study which was addressing this issue was a study published by Professor Galamini, who is my close friend and collaborator with a lot of studies. And he published in 2018 paper, which was addressing the fact of escalating treatment in patients with advanced Hodgkin lymphoma who were PET positive after 2 cycles, but in patients who were negative after 2 cycles and have a negative PET at the end of therapy, were randomized to 2 groups: those who did receive consolidative radiotherapy using this, let's say, old-fashioned criteria, and to those who did not receive consolidative radiotherapy because they were PET negative. And as you see from this graph, there is no statistical significance or clinical difference in the rate of progression in patients treated with radiotherapy and patients without this treatment. More detailed analysis showed that no matter what was the bulky lesion, whether it was smaller, 5 to 7 centimeters, 7 to 10, or even bigger, the bulky disease, there was no difference whether these patients did receive radiation or not, although you can also see from these graphs that patients with bulky disease have a little bit worse in general outcome than patients with not bulky or smaller lesions. However, please remember that despite of that, there was no difference whether these patients did or did not receive radiation, providing that they were PET negative, not only after 2 cycles of chemotherapy, it was ABVD, but also at the end of treatment after 6 ABVD cycles. And this is an example from actually it's a very recent paper, but this is a patient from that study in which, as you see, this is a patient with a bulky lesion, 11 centimeters in the mediastinum, and this is a baseline PET. At the end of chemotherapy, both interim PET was negative, but at the end of chemotherapy, the PET was negative, despite the fact that the lesion was still visible. It was a persistent mass, 6.2, 0.4 centimeters. So looking at these all other criteria, this would be, well, about partial remission, but not complete remission, according to the CT criteria. So these patients earlier should receive consolidative radiotherapy and would be subjected to all these late complications of radiotherapy, but that patient was randomized to non-further treatment, did not receive radiotherapy, and remains in complete remission at the time of publication of this paper, which is several years after being treated with in that trial. So this is really a proof that we can save a lot of patients from radiotherapy, which I would say was over-treatment and expose these patients to late complications. Does this apply to other treatment than ABVD? Actually, in a patient treated with escalated BCOP, I don't know how you treat this patient, whether you use more often ABVD or you use BCOP or use BCOP at all, but in Europe at least, some patients, some countries are using escalated BCOP as, and of course, Germany is the most advanced in this type of treatment. So they also addressed the question whether patients after treatment with escalated BCOP should receive consolidative radiotherapy or not. As you know, BCOP is even more toxic than ABVD. So when you add radiotherapy to that treatment, that was somehow also contributed to late complication after this type of treatment. So the German colleagues wanted to decrease the incidence of late complications. And in the important trial HD15, only patients who were PET positive were treated with radiotherapy. Patients with who were PET negative, DUVIL 1 to 3, did not receive consolidative radiotherapy. So from that paper, as you see, only 11% of patients did receive radiotherapy. So almost 90% did not. And in their first publication in 2012, as you see, there was no difference between patients who did receive radiotherapy and who were PET negative and were not treated with radiotherapy compared to other. And these results were confirmed by the longer observation. This is a paper published 5 years later, showing that patients who are PET negative, they are doing exactly the same as patients who were in complete remission, who did not receive radiotherapy by definition, and patients who were PET negative, despite of the presence of residual mass, they are also remain in remission. So these are the big achievements, those two which I showed to you. So to summarize our knowledge related to the consolidative radiotherapy in patients with advanced Hodgkin lymphoma, we can safely say that radiotherapy is not recommended in patients with negative end of treatment PET patients, regardless of the residual mass, providing, of course, that these patients have also interim negative PET. And in patients with positive end of treatment PET, if it's positive only in one lesion, especially in the mediastinum or in the bulky lesion, these patients should receive radiotherapy at a dose of 36 gray, because these patients may benefit from the treatment. But this is a very small number of patients, and only, as I said, these are the patients with positive PET lesions. Now, I would like to go to early stage Hodgkin lymphoma, in which the subject of radiation is more complicated. And as everybody knows, now still combined treatment, which is chemotherapy and radiotherapy, is a standard of care for patients with early stage Hodgkin lymphoma. So the question is, if really all the early stage Hodgkin lymphoma patients should receive this treatment. So to start the discussion about this, I would like to ask you, do you use a sledgehammer to crack a nut? Well, in most cases, not, but if you have a hard nut to crack, in such a situation, you may use this. Or if you have a very big nut to crack. These are two situations in which you may use radiotherapy, but in most cases, no. So let's say if this applies to most early stage Hodgkin lymphoma patients who are very different. we may have a patient with a small metabolic tumor volume, like the first patient. You can have a little bit more disease, or you can even have a patient with a lot of disease. And as I said, your nuclear medicine specialist can calculate the metabolic tumor volume in milliliters and say, let's say this first patient has 50 milliliters of the disease. The fourth patients have 500 milliliters of the disease. I strongly believe that maybe in the near future, the metabolic tumor volume maybe not substitute, but would enhance our staging system in Hodgkin lymphoma, and especially early stage Hodgkin lymphoma, in addition to the very well-known factors which are still used for the assessment of early stage Hodgkin lymphoma. I would like to remind you that we still use these factors as presence of bulky lesions, number of nodal areas involved, presence of B symptoms, age, and the ECR. And these factors are used by different study groups, but there are some slight differences between them. Nevertheless, the presence of B symptoms and the bulky lesions are the worst prognostic factors. And if we would like, let's say, to try to omit radiotherapy, for sure, this would be not the patient in whom we would start this type of treatment. But let's go again to some history. I just would like to show you the picture from the paper in which we was shown for the first time in terms of the treatment of Hodgkin lymphoma, that really we could cure the patients with Hodgkin lymphoma. And the author of this paper was Professor Henry Kaplan, who was working at that time at Stanford University Medical Center. And I would like to cite what he wrote in this paper, because I think it's very, very interesting what he wrote in this paper published in 1962, that we started a study which was a consequence of a difference of opinion among the staff of the Department of Radiology at Stanford. He added that he had long been persuaded of the view that Hodgkin disease, because at that time it was a Hodgkin disease, is a neoplasm, presumably of unifocal origin, and if it's localized, it should be treated with curative intention in its early stages. And he was right. As you see from the swimming plot, you know, this is an old-fashioned swimming plot graph. In a paper published in 1962, this paper showed that there are some patients who were cured using just radiotherapy. So radiotherapy had a very strong position in the treatment of early stage Hodgkin lymphoma. Later on, about 20 years later, a Manchester lymphoma study group showed that if we add chemotherapy to radiotherapy for patients with early stage Hodgkin lymphoma, these patients even are doing better. So that was a paper which somehow proposed a backbone of a current standard, which was confirmed some years later in a study which started in late 19th. It was H8 study, which showed that that chemotherapy plus radiation, and at that time MOP and ABVD were used, is a standard type of treatment for early stage Hodgkin lymphoma. But as I said, people did realize that for patients with early stage Hodgkin lymphoma, radiation can cause serious complication, especially related to the cardiac events and second malignancy. And as you see, after 20 years of after treatment, patients with early stage Hodgkin lymphoma start to die, not because of Hodgkin lymphoma, but start to die because of second malignancies or cardiac disease. And that's why investigators started to, at that time, started to search for the possibilities of treating patients with early stage Hodgkin lymphoma only with chemotherapy to prove that really it's a safe and better treatment. And one of the very important paper in which I would like to also to show you, to remind you, is a paper which was started by the Canadian group in which patients were randomized to patients treated with ABVD alone and patients treated with ABVD and some sort of radiation. The first publication, the first author of this publication is Dr. Ralph Mayer, showed that after 4 years of observation, overall survival was exactly the same, despite of the benefit, and there was a clear benefit in terms of the progression-free survival for patients treated with radiotherapy. So at that time, it was a result which was expected. No difference for overall survival, but better outcome in terms of progression-free survival for patients treated with combined treatment. However, 8 years later, as you see, and very few papers have such a long follow-up, and this also stresses the fact that in early stage Hodgkin lymphoma, we need really to have a long follow-up to be sure that our treatment is effective and safe. After 8 more years, it was clearly shown that patients treated with ABVD alone have a better overall survival. In fact, the hazard ratio for death was twice smaller for patients treated with ABVD compared to patients treated with combined treatment. So this was really a very important contribution of this group, showing that radiation, despite of being a very effective tool for treatment of Hodgkin lymphoma, can cause serious problems and decrease survival of patients. But of course, radiation, those who argue for or favor radiation still as a combined treatment say that radiation evolved now. At that time, when this paper was published, there was a bigger field used for radiation. Now we use a small involved field or involved site fields for treatment of patients with Hodgkin lymphoma. This is true. However, we have no clear signal that decreasing the dosage or decreasing the size of the field really improves survival. There's current papers showing that still patients who are treated with radiotherapy have, as you see, secondary neoplasm as a cause of death in 11% of patients, cardiac problem, 5% of patients. So still, this is an issue, and we have no really proof. It's a wishful thinking, rather, that that if we decrease the dose, if we have smaller field, that really this would translate to the lower incidence of complications. Some people even say that there's no safe dose of radiotherapy. So that's why in this modern era, and that's why I remind you that now we are in this modern era of treatment of Hodgkin lymphoma, in which we use PET-CT. This issue was again addressed. Could we omit radiotherapy in subset of early stage Hodgkin lymphoma? And the best choice, the best candidates were patients who were interim PET negative. So patient in whom disease responds to chemotherapy very well. And there were actually 3 important prospective trials launched some time ago, which ask a question: can we safely omit radiotherapy in the best prognostic subgroup of early stage Hodgkin lymphoma, which means patients with negative interim PET? And these studies have really a very minimalistic goal: non-inferiority, even with a margin between 7 and 10%, which means that even results worse than from 7 to 10% could be accepted and could be treated as a successful non-inferiority margin. However, these studies failed. None of these studies reached the non-inferiority margin. All these studies shows that patients with early stage Hodgkin lymphoma in whom radiotherapy is omitted, they have a worse progression-free survival. Well, at that time, despite of these unsuccessful events, people still have the feeling that for sure some of these patients do not require radiotherapy, but we cannot really well identify them. And how many of these patients? Let's do some math. I hope that you like math, and we could do some calculation. In all these studies, the rate of PET negativity was between 90 to 85%. And progression-free survival, so if we assume that progression-free survival means cure, was about, in this PET negative population, about 87%. So if we calculate the incidence of PET negative patients by the incidence, the rate of progression-free survival, we receive the results: 75% of patients who can be cured without radiation. So we know now that 75%, based on these studies, can be cured without radiation, just with chemotherapy, either 2, 3, or 4 ABVD cycles. So all investigators in 2022 would agree that omission of radiotherapy is a vivid option which should be discussed with the patient, especially in whom there are some contraindication to radiotherapy, like a young female who, despite of having bulky mediastinal, but not bigger, let's say, than 10 centimeters, but let's say 6, 7 centimeters, and now combined treatment should conclude the treatment with radiotherapy, but maybe these patients do not receive radiotherapy. So fortunately, now we have 2 prospective trials which address this issue: how to identify those 75% of patients who do not need consolidative radiotherapy in early stage Hodgkin lymphoma. These studies are rafting and radar. Radar study is launched by the British colleagues. Rafting study is an academic study, and actually myself with Professor Galamini, we are both principal investigators, in which patients with early stage Hodgkin lymphoma are enrolled, providing some inclusion criteria. So we enroll patients with stage 1, stage 2, without B symptoms and without bulky lesions. So these are the patients with early stage non-bulky Hodgkin lymphoma, similar population to the RAPID trial, which I mentioned before. And in this study, we address two questions. We address the question how to decrease the treatment for low-risk patients. And I will tell you what low-risk patients means in a minute. But also we address the question of high-risk patients in which even combined treatment is not sufficient for cure. The study, this is a graph of the study, which, as you see, is a little complicated because it's very personalized. Briefly speaking, patients with low metabolic tumor volume, because we assess prospectively in these patients low metabolic tumor volume, and patients with low metabolic tumor volume are treated only with chemotherapy, either 2 cycles or ABVD or 4 cycles or ABVD, depending on the presence of favorable of unfavorable risk factors using modified EORTC criteria. I will not go into details of that. They'll slightly change EORTC criteria. And these patients, if they are interim PET negative and end of treatment negative, they are treated just with chemo and are followed. Patients who have high metabolic tumor volume or have positive interim PET are high-risk patients, and these patients continue ABVD to 4 cycles. At the beginning, we thought that some of these patients may be escalated to BICO, but the current version of the protocol just include only, we use only ABVD. And after that, we use radiation as in standard combined treatment. And then these patients also receive nivolumab immunotherapy for a year as a consolidative maintenance treatment. So we would like, so the goal is to have really 100% PFS. As you know, the results of early stage Hodgkin lymphoma treatments are very good. So to improve that, we really need to have a goal of 100% for the whole group, providing that if patients, low-risk patients, would have a relapse within initial involved areas, they would receive radiation and nivolumab as well. And if we don't count this as event, so this would be a so-called delayed radiotherapy. So in fact, this treatment would be not different from high-risk patients. So we estimate that about 20% of the patients would receive radiation and nivolumab, and about 80% would receive chemotherapy only. We have enrolled as far 50 patients, and we now hope to finish enrollment in the next year. So I'm almost done because my time is almost finished. But coming back to early stage Hodgkin lymphoma, especially with unfavorable disease, do we have any possibilities to avoid officially radiotherapy as a consolidative treatment based on the solid data? Yes, we do. We have a very important German study, HD17 trial, in which patients were treated with 2 escalated BCOP and 2 ABVD cycles, and patients who are negative after 2 ABVD or 2 escalated BCOP and at the end of chemotherapy were randomized to either radiation or were not radiated. I'm not talking about the PET positive patient, they did receive radiation, but I'm talking about the PET negative patients. And the study showed that the patients who had a negative PET, both after BCOP and at the end of treatment after subsequent to ABVD cycles, if they are PET negative, they do not need consolidative radiotherapy, because there was no difference, as you see from these graphs, between patients who did receive and who did not receive consolidative radiotherapy. So this is current way of avoiding radiotherapy, especially in patients with bulky lesions in which the role radiotherapy is the greatest. So finishing my talk, if you want to use radiotherapy for patients with early stage Hodgkin lymphoma, choose wisely, since radiation today affects your patients tomorrow. So thank you very much for your attention, and I'm open for your questions and for the discussion. Finishing my talk, I would like to say my words, which are together with our Ukrainian colleagues and Ukrainian patients who, as you know, have a very hard time during the war with its neighbor. Thank you very much for your attention.
Thank you very much, Dr. Jain. You made it so simple, and you went through the whole so methodically to convince everybody. And I think many of us will probably follow exactly the algorithm that you advocated. We have some of our colleagues who may like to ask you some questions. We begin with Dr. Roshni.
Good evening, sir, and thank you for that excellent talk. Many of these studies which you have mentioned for early stage Hodgkin's lymphoma had included interim PET of dual 1 and 2 as negative, and 3 has been taken separately, a dual score of 3. So in that kind of situation with patients with unfavorable factors, would a dual score of 3 dictate whether one would add radiation or not in the era where tumor metabolic volume is still not standard of care?
Thank you for this excellent question. The discussion whether DUV 1 to 2 should be treated in early stage Hodgkin lymphoma as negative, or 1, 2, and 3 DUV score should be treated as negative was a very long one. And indeed, you're right that in the RAPID trial and in the German Hodgkin lymphoma study group, in early stage Hodgkin lymphoma, these patients only with DUV score 1 and 2 were initially treated as negative. But at least for the German study group, these patients were reviewed again, and they clearly showed that when you add DUV score 3 and analyze this patient, they have the same outcome like DUV 1 and 2. So we have the proof that we can safely use DUV 1, 2, and 3 still as a negative result of PET. So even if we have a bulky lesion and DUV score is 1 to 3, we should consider this as a complete metabolic remission. One more, I would say, proof is from this paper of advanced Hodgkin lymphoma, in which published by Professor Galamini. he used Deauville 1 to 3, and also he was not able to show any difference for the patients with Deauville score 3. So my personal attitude is that we have enough evidence that Deauville 3 should be treated as negative even in early stage Hodgkin lymphoma. I know that sometimes it is difficult in routine practice because such a result might be, let's say, not as good as you see Deauville 1 or 2. Yeah, I agree. But as I said, I think we should, these data are strong. So in my practice, I use Deauville 3 as a negative result. And I do not, for example, if I use sometimes to escalate bigger and to ABVD in that study, also they check that, and Deauville 3 was doing, this patient with Deauville 3 was doing as good as with Deauville 1 and 2.
Thank you.
Thank you, Dr. Anu.
Yes, thank you, Dr. Zaucha, for that very comprehensive presentation on the role of radiation in Hodgkin's disease. My question is specifically with respect to young patients with limited stage disease. So in early favorable Hodgkin's lymphoma, our current practice is to administer 2 cycles ABVD, and then if PET is negative, give 20 gray radiation and stop there. So is there a definite cutoff age below which you would consider this approach bad and instead give 2 more cycles of ABVD and avoid radiation? This question, of course, is with respect to late risk of head and neck cancer in children.
Yeah, you know, it's a very valid question, but as you know, that this is why we started this rafting trial, because I cannot answer this question based on any data that we can use any cutoff. Second, we, even don't know whether if you have an early favorable Hodgkin lymphoma patient, patients would benefit from 2 more ABVD cycles. My personal approach is that if my personal approach is to enroll these patients to the rafting trial, because in this trial, I assess MTV, I assess interim PET, and according to the protocol, if I have a favorable Hodgkin lymphoma, I use now only 2 ABVD cycles, no radiation at all. And why I think this might be a safe approach, because even if some of these patients do relapse, you can safely salvage them with this delayed radiotherapy alone. Because, it's unresolved question how to salvage patients who do relapse after chemo alone. And if you look in details in the big studies, the RAPID trial, for example, or H10 study, 70% of the relapses occur in the initially involved area. So it is very likely that delayed late radiotherapy can cure them because it's a very effective treatment. In our trial, we added immunotherapy. Why? Because that was my original proposition of this delayed radiotherapy, but people were not confident that would be enough, since if they relapse, this means that they have not a good disease, and maybe radiotherapy alone after break between chemo will be not sufficient. Well, I have no arguments to say that I'm sure that radiotherapy will be sufficient, but I was very sure that these patients do not require second-line intensive chemo or autologous transplantation for such a relapse. But I did see such patients treated that way, that if they did relapse with early-stage Hodgkin lymphoma, if they did not receive radiation, they were treated very intensively. But coming back to your question, Now, I cannot say that there's any age cutoff. And I even cannot say if 4 cycles of ABVD is better than 2 cycles alone, and it's equivalent to radiation dose. There's not such a study showing that patients with early stage Hodgkin lymphoma treated with 4 ABVD cycles are doing exactly the same as patients with 2 ABVD and radiation. So we cannot assume that 2 ABVD will substitute 20 grays of radiation. But as I told you, using this math, 75% of these patients do not require radiation. So the really question is how to identify them. And I haven't mentioned in the lecture, but in the rafting trial, we also measure cell-free DNA. And it might be that cell-free DNA will be more predictive in terms of the response than PET alone. So if we maybe, and let's say cell-free DNA, of course, is not used for routine treatment, but this may change soon. And if we can use both interim PET results, MTV, and cell-free DNA monitoring of this patient, then we probably could safely omit radiation. But now the response to your question is, I would discuss with the patient, okay, you have early stage favorable Hodgkin lymphoma. I can treat you with ABVD, 2 cycles, 3 cycles, and stop treatment. However, you may have a chance of having relapse. And don't be, mad with me that if you have a relapse because I don't give you a proper treatment. I can give you radiation, but radiation have a long-term complication. And I ask my patient, what would like to choose? Some patients do prefer combined treatment. Some patients, I would say sometimes more intelligent patients, well, they, and having said that have 70% of chance of being cured without radiation, they take this chance. And so that was routine treatment before rafting trial. Now I have rafting trial. So all my early stage Hodgkin lymphoma patients, I enroll to the trial, and I feel really very safely because I can address high-risk patients with combined treatment with nivolumab, and low-risk patients in which I treat them only with chemo and follow them without any further treatment, just with cell-free DNA.
Thank you.
Thank you. We just have a couple of minutes left. Maybe a very quick question from Dr. Rajiv. Rajiv, be very quick.
Yes, sir. Thank you, ma'am. I have just 2 questions. Number 1 is, if an interim PET is negative, because I work in a resource poor setting, if an interim PET is negative, the end of treatment PET, whether it adds any value, or if we can avoid the end of treatment PET if the interim PET is negative. Number 1. Number 2 is, in unfavorable patient, can we consolidate with autologous transplant in CR1 in Hodgkin's lymphoma?
So the first question, if I got you. So if you have interim PET negative, should you do the PET after end of treatment? Yeah. Yes. I would say, early favorable Hodgkin lymphoma, interim PET is equivalent to the end of therapy PET because it's 2 cycles, right? So this is, but for patients with unfavorable Hodgkin lymphoma, myself, in a routine practice, I do interim PET. If it's interim PET negative, I do not PET after 4 cycles. And if they're treated with a standard treatment, I use radiation and then do PET after radiation, 3 months after radiation. If I avoid radiation after discussing with the patient, I do end of therapy PET. That's answer to your question. The second question, could you please, because I'm not sure if I got it. What's the second question?
In unfavorable Hodgkin's lymphoma, is there any role of consolidating with autologous cell transplant?
I would say now in our current modalities, I wouldn't do it. You know, the chance of having late complication of even acute mild leukemia, I would not recommend this at all. There's so many, of course, it depends on the possibilities. You know, in different countries, there are different resources, but even in our country, which is not a very rich one, in our country, that would be not an option in early unfavorable Hodgkin lymphoma as a consolidative treatment. Not at all.
Thank you.
Thank you, Rajiv, and thank you, Dr. Jain. That was wonderful. Unfortunately, we have run out of time, but I'm extremely grateful to you for having come all the way, discussed this, and you did it so beautifully and convincingly. Thank you so much.
Thank you very much for this kind invitation. It was a privilege to be able to be a part of this great event. Thank you very much.
Yes, sir. Thank you. We'll move on to the second session of the day. And it's my great pleasure to once again introduce Dr. Maddocks from Ohio, USA. She has been our, I would say, regular speaker, whether it is in person or through the video conferencing. For those of you who have not known her and you are very, very young, she's Professor, Clinical, Division of Hematology, Associate Division Director for Ambulatory Operations, Division of Hematology, Medical Director, Infusion Services, Director, Lymphoma Program, The Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, Richard J. Solow Research Institute at Columbus, Ohio, USA. And today she's going to speak to us on mantle cell lymphoma. So over to you.
Thank you, Dr. Agarwal, for that kind presentation. I'll just get my slides up here. Trying to get this in slide presentation here. Okay, are you guys able to see my slides?
Yes.
Okay. Thank you again for that kind presentation, and thanks to Dr. Agarwal and the Mumbai Hematology Group for inviting me to speak again. It's always a pleasure to interact with this group. So I'm going to talk today about mantle cell lymphoma. These are my disclosures. What I thought I'd do today is give an overview of where we stand at in the treatment of mantle cell lymphoma, discuss some of the data that's been either presented or published in the last year, and then discuss some of the challenges that we continue to face with the treatment of mantle cell lymphoma and some of the ongoing trials that will hopefully address some of these challenges. So we've come to understand that mantle cell lymphoma, like many other malignancies, is really a heterogeneous disease. And outcomes of mantle cell lymphoma seem to be driven by the disease biology. While we've identified prognostic factors in different factors associated with biology that help us define how patients are going to do with treatment, we've not yet reached a point where we're able to use these prognostic factors in biology to drive treatment decisions. And part of that is because some of the high-risk biology, we don't necessarily have therapies that have shown to be more effective in this patient population. That being said, we've no doubt improved survival in our patients with mantle cell lymphoma over the last 2 decades, potentially even doubled the survival that we've seen in the era of current therapies. So using rituximab in the frontline treatment of mantle cell lymphoma, including using it in a maintenance approach, and patients who are going to receive autologous stem cell transplant, we know that they benefit from high-dose cytarabine in the induction therapy versus other induction therapies. However, we really don't know that with all the current therapies in our current treatment landscape, that all patients benefit from some of our current treatment approaches, and could do better to better understand who benefits from some of these more intensive approaches. The novel targeted therapies, such as the BTK inhibitors, have no doubt revolutionized our treatment at relapse for mantle cell lymphoma. And more recently, we've seen approval in some places with the cellular therapies with chimeric antigen receptor T cell therapy, that have really improved outcomes at relapse. However, resistance remains a problem with these agents, and really access is a huge problem. So outside of the US, many places don't have access to CAR T products or really even BTK inhibitors everywhere. And even within the US, access to these agents, cost, and the toxicity remain challenges. And lastly, a young patient who's diagnosed with mantle cell lymphoma, although they have options and can achieve long remissions, we know that they're still most likely to die from their mantle cell lymphoma. And so we have room for improvement here. To talk a little bit about the biology, in 2016, the WHO updated to define two major subtypes of mantle cell lymphoma: classical, or sometimes referred to as nodal, and then leukemic non-nodal mantle cell lymphoma. These not only have a different development, but they also behave different clinically, with those patients with leukemic non-nodal mantle cell lymphoma often presenting in what we think of like a CLL-like presentation, with peripheral blood and bone marrow involvement and splenomegaly, but really minimal or no lymph node involvement. These patients often have more indolent behaving disease at diagnosis and can be monitored without treatment. However, there is a small percentage of these patients who will develop TP53 mutations and will have very aggressive behaving disease when that happens. Ki-67, or proliferation of cells, has been shown to be independently prognostic. So those patients whose tumor have Ki-67 expression greater than 30% have worse outcomes with standard treatments. There's been a prognostic score that combines MIPI in addition to Ki-67 that's divided patients into 4 distinct risk groups. And this risk has shown to hold in both the mantle cell younger patient population and elderly patient population treated. So really this is independent of the treatment approach as a prognostic factor. And lastly, I'll mention TP53 mutations. We know that TP53 mutations predict poor overall survival, and this also applies across treatment, regardless of how intense or less intense the treatment approach is used. About 10% of patients will have a TP53 mutation at diagnosis, and the median overall survival of these patients is less than 2 years with our standard treatments. It is common as patients receive further therapies for them to develop TP53 mutations and have more aggressive disease behavior. Pivoting to the different frontline treatment approaches. So initial therapy, there's still really no standard treatment approach to mantle cell lymphoma. There's many different treatment approaches that have shown to prolong progression-free survival. Questionable if any of these really provide an overall survival in the frontline setting. But with the prolonged progression-free survival does in many cases come an increased risk of toxicity. And really these have to be weighed against each other in the different patient populations. I would still say that the standard treatment approach is chemoimmunotherapy for patients. Often this is divided into patients who are considered young or fit for more intensive approaches, or older or less fit for those intensive approaches. So older or less fit patients are often treated with chemoimmunotherapy regimens followed by potentially rituximab maintenance, whereas younger patients are offered more aggressive chemoimmunotherapy followed by consolidation autologous stem cell transplant with also a role for rituximab maintenance. So because the novel targeted therapies have been so effective at relapse, there's a lot of ongoing interest in adding these to the frontline treatment of mantle cell lymphoma. And ongoing trials have looked at adding these to chemoimmunotherapy, using these in combination with in chemo-free ways, and also as maintenance approaches. There's also investigation into risk stratified treatment approaches, particularly in young patients. Does everybody really benefit from an autologous stem cell transplant? And using things like minimal residual disease to help us define treatment decisions and length of treatment. Before we talk about those treatments, I do want to mention that observation is an appropriate treatment strategy. So no treatment, watch and wait in select patients. I already mentioned the leukemic non-nodal patients, which often can be observed at diagnosis and not require treatment. But Dr. Martin was first to report on this cohort of mantle cell lymphoma patients who could be observed at diagnosis without requiring treatment. The median time to treatment in those patients was 1 year, but there were patients who were observed for up to 5 years without treatment. Most importantly, he showed that by deferring treatment in a patient who didn't really have indications for treatment, that this did not affect their overall survival. Many other groups since him have shown the same thing, that there's this cohort of patients with classic mantle cell lymphoma who tend to have low tumor burden, asymptomatic, normal CBC, normal LDH, who can be observed without treatment for a period, and this does not affect their survival. Additionally, Dr. Cohen looked at the treatment in those patients when they did progress to NEAT requiring therapy, and showed that these patients, when they're treated, don't necessarily benefit from intensive treatment strategies, even if they're candidates for such. That probably just speaks to the disease biology. The more indolent disease to start with may not require more intensive approaches when it does progress to requiring treatment. Looking at treatment strategies, as I said, I still think, the majority of the time, at least at larger centers, we think of these patients as transplant eligible or non-transplant eligible, although that may be changing, and we'll discuss that. But really, for patients who are considered not fit for more intensive approaches, they're treated with chemoimmunotherapy. There are several regimens, including R-CHOP, BR, VR-CAP, and RBAC, that have shown activity in this setting. I would say that in the US, the most commonly utilized regimen by far is the bendamustine rituximab regimen, which was shown in a randomized trial that included mantle cell lymphoma patients to prolong progression-free survival in this cohort of patients, included with a PFS of about 3 to 4 years. With the BR regimen. Now, this did not include maintenance. Maintenance in this population of patients, we know that it's been shown to improve progression-free survival and overall survival when given after R-CHOP chemotherapy. The data with bendamustine have been a little less clear. So there was only one prospective randomized trial that evaluated this, and it had small patient numbers. There was not a significant benefit to rituximab maintenance, although there was the data trended towards a PFS benefit. It was not statistically significant. However, since then, several large retrospective studies have indeed shown that patients benefit from rituximab maintenance after bendamustine rituximab in the first line. And I just show a recent study that was actually just published in JCO from last week, which was a trial or a retrospective data looking at 2 large populations of patients treated in the US. One from the Flatiron data set that is patients treated in the community setting, and then a cohort of patients treated across different academic centers. And this showed that there, of course, in a retrospective manner, so with the limitations of that, but this showed that in patients who were treated with frontline chemotherapy and not taken to autologous stem cell transplant with both BR and R-CHOP, that there was an PFS, but also an overall survival benefit to giving rituximab maintenance with these less intensive approaches. And this was actually shown in both the cohort of patients treated in the community setting and the validation of patients treated at the academic center. In my practice, I do use rituximab maintenance in these patients for the majority of the time. I think COVID has kind of thrown a wrench in some of those things, but I think that in mantle cell lymphoma, there is collective data showing benefit. I now want to just pivot and talk about 2 frontline BR trials that have been reported out in the last year. So the first one is a large intergroup trial, the EA1411 trial, and this was actually a 4-arm trial. So this was set out to answer 2 questions. The first was about induction, and the second about maintenance therapy. So this randomized patients to treatment with standard BR versus BR in the addition of bortezomib, with a second randomization to maintenance therapy with either standard rituximab or rituximab plus lenalidomide. This trial was reported out as far as the induction phase. The maintenance phase has not been reported out. But this trial did not meet its primary endpoint of progression-free survival. So there was the 2-year PFS with BR was 75%, and with the addition of bortezomib was approaching 80%, which was not statistically significant. different. I showed this largely because if you look at the median PFS in both arms, it's a little, 5 years plus. And as I mentioned, I think that most of the time when we're looking at BR-based regimens that use rituximab maintenance, without maintenance, we are seeing about 3 to 4 year PFS. And I think BR with maintenance rituximab, we're looking at around a 5-year PFS in a lot of prospective studies. I now like to talk about the SHINE trial. So we'll spend a little bit of time on this trial just because this trial was long awaited. And this is new data that came out and was presented at ASH, ASCO in June and was published in the New England Journal of Medicine. So the SHINE trial was a randomized double-blind phase 3 study in patients who were 65 or older with untreated mantle cell lymphoma and not considered candidates for intensive therapy with stem cell transplant. They enrolled 523 patients to this trial and randomized them in a 1-to-1 fashion to standard BR for 6 cycles, followed by rituximab maintenance every 8 weeks for 12 cycles or 2 years of maintenance, in addition to placebo, versus standard BR and rituximab in addition to ibrutinib, which was given through induction maintenance and continued until progression or unacceptable toxicity. This trial did meet its primary endpoint. The median progression-free survival of the standard arm was 52.9 months, and the median progression-free survival of the ibrutinib arm was 80.6 months for a PFS benefit of 2.3 years with the addition of ibrutinib. Now looking at the toxicity, this shows most common treatment emergent adverse events occurring in 20% or more of patients, with the most common toxicities being neutropenia, diarrhea, and nausea. There was a higher incidence of rash and pneumonia in the ibrutinib arm. When you look at the AEs of clinical interest, so adverse events that we know to be associated with BTK inhibitors, there was double the rate of any grade bleeding reported in the ibrutinib arm and over double the rate of grade 3 to 4 bleeding in the ibrutinib arm, with a little bit higher incidence of major bleeding. Atrial fibrillation was over double in the ibrutinib arm in higher rate of grade 3 or 4 atrial fibrillation. Hypertension a little bit, but fairly similar, and arthralgias were similar across the 2 arms. When you look at overall survival, there was no difference at the current follow-up in overall survival, with median overall survival not reached in either arm. When you look at deaths on study, you see that deaths due to progressive disease were higher in the placebo arm compared to the ibrutinib arm, with 54 deaths due to progression in the standard arm versus 30 deaths due in the arm with ibrutinib. However, when you look at deaths due to adverse events, there was a higher number of deaths in the arm with ibrutinib than there were in the arm, the placebo arm. So, when you look at this data, kind of stepping back and looking at all together, it was a positive trial. It met its primary endpoint of improvement in progression-free survival. The median time that patients were on ibrutinib was 2 years, and there was a much higher incidence of some of these toxicities. So really, the benefit in PFS does come with increased toxicity and without, at this time, any difference in overall survival. So I think that this is probably not, changing the standard across all populations of elderly patients with mantle cell lymphoma. However, I think that there are probably patients who benefit from being in remission mentally, emotionally, and, there is a benefit to prolonging PFS. My concern is that benefit ideally does not come with the increased risk of toxicity. So I think questions that this trial raises are, will the newer generation BTK inhibitors, which have been shown to maybe be a little bit better tolerated, would they be better options? So you could have this improvement in PFS, but maybe at not the same cost of toxicity. And maybe then you could see an overall survival benefit. Hard to say, but at least your PFS benefit wouldn't come with that risk of toxicity. I think with the median time of patients on BTK therapy being 2 years, the question is really, does this need to be continued until progression, or is it something that could be used in combination as a time-limited approach, and then maybe even patients that could be retreated with BTK in the future if they relapsed? I also want to mention the rituximab and ibrutinib, an elderly mantle cell study that was published in JCO also in the past year. So this was a single-arm phase 2 trial that looked at on this non-chemotherapeutic approach in patients who were elderly or not candidates for more intensive approaches. This trial enrolled 50 patients, 28 of which came off study. And if you look at reasons for off study, 21 or 42% of those patients came off due to intolerance. 22% of which were actually due to atrial fibrillation. So the results of this trial were impressive. The overall response rate was high at 96%, with 71% of those patients achieving a complete response. Median PFS and overall survival were not reached, with 3-year PFS of 87% and 3-year PFS of, or 3-year overall survival of 94%. So this is an effective regimen, but does raise concerns about the toxicity. I think that this shows us that just because we're chemo-free does not mean we're toxicity-free. And this also raises the question if there is a role for time-limited therapy here. So that time-limited therapy could save us cost, and it could save us potential toxicities. It also shows us, I think, that we have to do some baseline assessments in these patients, because patients who are at higher risk in this elderly population of cardiac morbidity, such as hypertension, atrial fibrillation, may be more likely to have complications with this. So in this population of patients, there's a number of ongoing trials. I'd like to highlight just a few of the big ones or mention them to say what I think has a potential to change things. So the SHINE trial, there's an ongoing trial with acalabrutinib, which is designed essentially similar to the SHINE trial, but uses acalabrutinib instead. As I mentioned, will a BTK inhibitor with at least less reported toxicities in other trials show us more benefit than ibrutinib did in the SHINE trial? I think both the ENRICH and Magnolia trials are interesting because they actually look at combining our chemo regimens versus non-chemo with our BTK. So the ENRICH trial allows patients investigators' choice of chemo induction, so BR-R-CHOP with maintenance, compared to R-ibrutinib plus continuous ibrutinib. The Magnolia trial uses just BR and randomizes patients to that versus R-zanubrutinib, so another second-generation BTK inhibitor. I think, one of the challenges with this trial is without maintenance rituximab, you're kind of setting up for most likely a PFS benefit, but we'll see what these trials show. And then the other trial I'd like to mention is the OASIS-2 trial. And this is a trial that randomizes patients as all non-chemotherapeutic approaches, so to the doublet of the CD20 obinutuzumab plus ibrutinib versus obinutuzumab plus ibrutinib plus venetoclax. And I think this is interesting, one, because there's questions, is a doublet or is a triplet really better than the doublet? What does that provide in terms of efficacy benefit versus toxicity? And both of these arms are a time-limited treatment approach. So this will, help show us what time-limited therapy versus just continuing these oral agents until progression or unacceptable toxicity. So now to pivot and remain in frontline treatment, but talk about patients who are considered candidates for more intensive approaches. So I would say that, by far probably the most two utilized induction approaches here in the US and probably in most places are based on the Nordic or the European mantle cell lymphoma data. The Nordic lymphoma with our Maciej and our high-dose cytarabine, and the European mantle cell data with our CHOP alternating with our DHAP. So both of these trials showed a benefit to using high-dose cytarabine in induction therapy when autologous stem cell transplant is used, with median progression-free survivals somewhere between the 8 to 10 year range. So I think, when you look at randomized data, including transplant, the only randomized data we have evaluating the role of autologous stem cell transplant in frontline treatment for mantle cell lymphoma is prior to the standard use of rituximab. And so there is, it does bring into question in the role of the current therapies we have, is using autologous stem cell transplant in all these patients necessarily the right thing to do? So I just want to, present a few data from a few retrospective studies. Again, these aren't prospective studies. We'll get to that in a minute, but 2 retrospective cohorts that have evaluated this question. So the first was an article, this is a little bit older, but it was over 1,000 patients treated at US academic centers that were considered transplant eligible, and what treatment approach was utilized and if they received transplant. And it showed in this transplant eligible population of patients that there was a progression-free survival benefit to those patients who underwent auto stem cell transplant with diagnosis. However, while there was a trend toward overall survival benefit, there was no overall survival benefit. There were a few groups of patients who in the look to potentially have a benefit in overall survival to transplant, but the study really wasn't powered to look at outcomes in those patients. And the second set of data comes from that set that was just published last week in JCO, looking at real world outcomes in those 2 cohorts of patients treated in the US. One cohort of patient over 4,000 patients evaluated, but was treated in community centers. And then the validation cohort was patients that were treated at academic centers across the US. And this evaluated a number of things, including the rituximab maintenance. It was just looking at treatment patterns and outcomes for first treatment of mantle cell lymphoma. This did look at patients who were considered transplant eligible, so less than 65 years of age and responding to their initial chemoimmunotherapy regimens. And it did not show a survival benefit to consolidation with autologous stem cell transplant in either cohort of patients. Again, none of this is prospective data, but it really begs the question, are all patients benefiting from auto transplant in our current era of therapies? And then I'll just mention maintenance, rituximab maintenance after autologous stem cell transplant. So we've seen that one study that showed in both a PFS and overall survival benefit to rituximab maintenance after transplant. This was a trial that looked at 4 cycles of an RDHEX or DHAP regimen followed by autologous stem cell transplant and rituximab maintenance. But I would say that based on the results of this trial, that we standardly use rituximab maintenance post-auto transplant regardless of induction regimen. So really, I want to talk about or just mention the 2 ongoing trials that I think are going to help us get to the transplant question in the era of current therapies. The first is the E4151, and this is a large randomized trial being conducted in the US. And this is looking at the role of autologous stem cell transplant in patients who achieve minimal residual disease negative state with induction therapy. So we know that patients who achieve an MRD negative state with their induction chemoimmunotherapy have prolonged progression-free survival after autologous stem cell transplant. And the question really is, do patients benefit from the transplant if they're already in an MRD negative remission, or is it really the patients that transplant achieves MRD negative remission benefit? Because we also know that an MRD negative after transplant is shown to improve progression-free survival than those patients who remain MRD positive. So this trial, it allows all patients, but essentially patients who continue to have an MRD marker or achieve only a PR to treatment are taken to what's considered standard with autologous stem cell transplant and rituximab maintenance. Whereas those patients who are MRD negative, and this is done by the clonoSEQ sequencing, they're randomized to what's considered standard treatment with autologous stem cell transplant followed by rituximab maintenance versus rituximab maintenance alone. Hopefully answering the question in this population of patients, is auto beneficial? And this would help us to, potentially use this risk stratified approach. The second trial that I think will help us to evaluate the role of transplant is being a European study, and this is a triangle study. And this is evaluating both the use of transplant and the use of BTK and inhibitor therapy in the frontline treatment. So this is a 3-arm trial that randomizes patients to what's considered the standard treatment with R-CHOP, R-DHAP for 6 cycles, followed by autologous stem cell transplant, versus standard chemotherapy plus ibrutinib BTK inhibitor in induction, followed by transplant, followed by ibrutinib maintenance, versus ibrutinib in induction, no transplant, followed by just ibrutinib maintenance. So again, both of these different design trials, but may help us to answer, if patients benefit from transplant in the era of the current therapies, or at least which patients are still benefiting from transplant. Now, I'm going to pivot again, and this is going to be to relapse treatment approaches. So looking at relapsed treatment for mantle cell lymphoma, I think really the Bruton's tyrosine kinase or BTK inhibitors have really changed our outcomes in relapse disease and our ability to get effective therapy into these patients. So currently in the US, there are 3 approved BTK inhibitors for the treatment of relapsed mantle cell lymphoma. The first generation BTK inhibitor, ibrutinib, and the second generation BTK inhibitors, acalabrutinib and zanubrutinib. So these agents have never been compared in a randomized fashion in mantle cell lymphoma. But if you look across the studies and take into consideration difference in patient populations and difference in the way that response assessment was done, I think that probably they have very similar efficacy in this setting. So median progression-free survival is somewhere between probably 18 and 24 months with these agents. It has been shown that these agents produce the best responses when they're used at first relapse. And so I think that, the majority of patients are given a BTK inhibitor at first relapse. There's still probably a role for chemoimmunotherapy in patients who achieve very, very long remissions to an induction chemoimmunotherapy. But even in these patients, I tend to offer them one of these BTK inhibitors. Where there potentially is a difference in these BTK inhibitors, and I alluded to this in the frontline data, is in toxicity. So we've seen randomized data in CLL with ibrutinib and acalabrutinib, and randomized data in Waldenstrom's with ibrutinib and zanubrutinib. And it's been shown that the risk of cardiac toxicity, including atrial fibrillation, hypertension, and the risk of bleeding seem to be less with the acalabrutinib and the zanubrutinib. So these are probably a little bit better tolerated treatments, even though, again, it's not clear there's any difference in efficacy. So while these therapies nearly, most patients are going to respond to BTK inhibitor therapies, and some can get prolonged durations of response, but the fact remains that almost all patients are going to likely become resistant to BTK inhibitors. And survival after progression on BTK is pretty poor. So it's been shown that median overall survival after patients progress on a BTK inhibitor is about 6 months. Now, a lot of this data was collected after the initial approval of BTK inhibitors. And I think, there are some more options for treatment available now. And we've gotten a little better about treating patients who progress on BTK inhibitors, because we know that if you withdraw the BTK inhibitor while they're progressing, there's patients who tend to have more rapid progression. And so we've learned that it's good to have your next line of treatment kind of set up and sometimes even overlap them. But still the fact remains that the overall survival after progression on BTK is not great. So a lot of effort has gone into improving outcomes in what has been done. So combination therapies, can we improve on single agent responses with BTK inhibitors by looking at different combinations? Newer BTK inhibitors, so the non-covalent BTK inhibitors, evaluating them, and then novel agents. So we've seen the approval of chimeric antigen receptor T cell therapy in mantle cell lymphoma in the US. But again, these aren't therapies that everybody can access. There is toxicity associated with this. So therapies either in patients who are unable to access that or who even progress after that. So there's been a lot of combinations with BTK inhibitors studied, and I can't discuss all of them because of time, but I want to mention the combination of ibrutinib plus the BCL2 inhibitor venetoclax. And the reason I mentioned this combination is because this is where we're going to have the most data, because there's an ongoing randomized phase 3 trial in this setting. So I think that if there's a potential to change the treatment landscape here, it's with this combination because of the phase 3 trial. So this combination was first reported in the AIM study, and that trial looked at 21 patients with the majority who had relapsed refractory mantle cell lymphoma, and showed a very high overall response rate, with nearly all patients achieving a complete response, a median progression-free survival of 29 months, and a median overall survival of 32 months. This did show activity, 50% CR rate in the patients with TP53, suggesting there may be benefit, some benefit in that high-risk population. This has led to the Simpatico trial. So that is the randomized phase 3 trial that is randomizing patients to single agent ibrutinib therapy, which is a standard of care, versus ibrutinib plus venetoclax. This trial did have a safety run-in of 21 patients, showing similar responses to what the AIM trial showed. So I think, again, this, because there's an ongoing randomized trial and we await results of that this is the combination that most likely has the potential to most immediately impact the future. And the question will be, does that higher rate of CR translate into improvement in progression-free survival, and what are the toxicities? I think another question that'll be of interest eventually will be, if this combination is better, is this something that we can give in a time-limited approach? So there were 5 patients on the AIM trial who were in MRD negative remissions who went off treatment. 4 of those 5 who had remained in remission at the time of reporting of the data. So potential to give a time-limited therapy, again, just like the frontline, is of interest because it reduces costs and it reduces toxicity. There are a number, as I mentioned, combinations that have been evaluated, BTK inhibitors with the different CD20s, with venetoclax and CD20, with Lenin, CD20, NF-kappa-B, CDK inhibitors, PI3K inhibitors. When you look at all this, it's hard because there's a lot of these single arm phase 1, phase 2 trials, but a lot of these have shown similar patterns of results, in that the combinations show similar overall responses to BTK inhibitor alone. They show higher complete responses, but also higher toxicity. What is not clear is if it really has shown an improvement in progression-free survival. Some of them have looked similar, some of them have looked like they may benefit, but again, none of it's been in a randomized fashion. So, if these higher CRs show more toxicity, but aren't translating into a higher PFS, then we may not be really getting anywhere with these combinations. Some of them have shown, however, that there's benefit in high-risk subgroups, such as the patients with high Ki67, blastoid disease, or TP53 mutations. And it may be such that the combinations are better in a select number of patients, but not necessarily for the general population of mantle cell lymphoma patients. I will say that the OASIS trial, which evaluated obinutuzumab plus ibrutinib and venetoclax, did have very promising 1 and 2 year PFS in that cohort of patients, but the numbers were very small. Again, so hard to say there without randomized data. But there is an ongoing trial, albeit in frontline, that we discussed in that. So other kind of efforts, I want to mention therapies that we don't have access to, but that have shown promise. So pirtobrutinib, or LOXO 305. So this is a reversible BTK inhibitor, or non-covalently binding BTK inhibitor, that's been studied in both mantle cell and CLL in patients who have progressed on prior BTK inhibitor. So this was just updated at EHA, where they enrolled 134 patients with mantle cell lymphoma, 111 who were assessable for efficacy. So 100 of those patients had received prior BTK inhibitor therapy, the majority of which had gone off because of progression on BTK, although there was a portion of patients who'd gone off because of toxicity. So in this population of patients, their overall response rate was 51% with a 25% CR rate. There was a small number of patients, 11 patients, who had not been exposed to prior BTK, showing an 82% overall response rate, but those numbers are small. They showed efficacy in patients who had progressed post-transplant and post-CAR T cell therapy. So this is interesting. This agent is interesting because unlike the other BTK inhibitors, where if a patient progresses on them, you don't get activity from using another BTK inhibitor, this is actually shown to be active in patients who progress on first and second generation covalent BTK inhibitors. It's also been shown to have a very good safety profile. And so I think that we don't have results on duration of responses, although with a median follow-up of 8 months, 60% of the responding patients did remain on treatment. So I think, the question will be, where does this fit into the treatment landscape in mantle cell lymphoma? And that may be different than for CLL, or it may be the same. Will this be something that we really reserve for patients who progress post-covalent BTK, or will it be something that's used in place of covalent BTK? There is an ongoing randomized phase 3 trial with this agent, and patients are randomized to investigators' choice of covalent BTK, so ibrutinib, acalabrutinib, or zanubrutinib versus pirtobrutinib. Chimeric antigen receptor T cell therapy. So, after BTK, I would say that this was the next biggest change in the treatment of relapsed refractory mantle cell lymphoma. This is approved for use in the US. We have this one product approved, so the KTX19 or Brexucel product. This was based on the ZUMA-2 study, which was a phase 2 trial that showed an overall response rate of 93% with using CAR T cell therapy in relapsed refractory mantle cell lymphoma with a 67% complete response rate. Now, toxicity wasn't a concern in this trial. So 91% of patients experienced any grade CRS, with 15% experiencing grade 3 or higher, and 63% of patients experienced any grade neurological event, with 31% showing grade 3 or higher. But, not only has this been an effective therapy for these patients, but of interest is that it's been shown to be effective in all risk groups. So patients with high Ki-67, their outcomes were no different than those patients with lower Ki-67, patients with high risk MIPI, and patients with TP53 deletions. So an agent that is effective in those high-risk population of patients where other therapies haven't been so effective. Other toxicities in addition to CRS and cytokine release have included cytopenias. So 94% of patients experience grade 3 or higher cytopenias, with about a quarter of them persisting beyond 90 days of treatment. A third of patients had infections, and there were a few grade 5 toxicities on trial. So at ASCO this year, the 3-year follow-up of ZUMA-2 was presented. The median progression-free survival in the total population of patients was 25.8 months, but not reached in those patients who achieved a CR, and median overall survival 46.6 months and not reached in those patients who achieved a CR. So I think, this is shown with longer follow-up to be a very effective therapy in relapsed refractory mantle cell lymphoma, especially in those patients with high-risk disease. Now, there is ongoing studies. All the patients on this trial were previously treated with BTK inhibitors, and there's really a question of, is that necessary, or are there certain patients where CAR T could even be put before a BTK inhibitor, which, as we move BTK inhibitors into the frontline setting, that may be less of a question. Not approved, but I'd like to also mention is the Transcend study. So this is a liso-cel. So this is another autologous CD19 product, but this was presented in 2020 at ASH, and this is not approved for use here in the US. It's approved for relapsed refractory large cell and follicular. But this trial showed in a smaller number of patients, but showed similar overall response in CR to that of the other product, but it did seem to be a little bit better tolerated, with lower rates of any grade CRS and neurotoxicity and lower rates of grade 3 or higher. So potential for in the future for maybe other autologous CAR-19 products with improved toxicity profiles. Also presented this year at ASCO, so which is why I mentioned it. We know that the population of patients treated on CAR-T trials are a very select group of patients, but there's data looking at from the U.S. CAR-T cell consortium that looks at patients treated with standard of care, Brexucell, or the KTE X19 product. And 80% of the patients treated in this cohort of patients as standard of care would not have met criteria for the ZUMA-2 clinical trial. However, they showed similar outcomes to what was seen in ZUMA, both with respect to activity and with respect to toxicity. So the follow-up is short in this 147 patients, but the 12-month PFS rate predicted was very similar to that which was seen in ZUMA, as was the 12-month overall survival. The incidence of CRS and ICANS were also similar. And then I'll just mention briefly two other potentially promising agents. So the ROR1 antibody drug conjugate has been presented as early data. So ROR1 is broadly expressed on hematologic and solid tumors, but not normal adult tissue, and this can be targeted with antibodies, antibody drug conjugates, and even bispecific antibodies. So updated at ASH of this year was data on the phase 1 study of the VLS-101 or ROR1 ADC that treated 17 patients with mantle cell lymphoma, so low numbers, but this showed overall response rate of 53%, including 40% of patients who'd had prior CAR-T. The median duration of response is 10 months. So this is still early, but I think there's this will be evaluated in phase 2 data and maybe something to look for in the future. And then the last thing I want to mention is bispecific antibodies, because these are exciting in relapsed refractory B-cell malignancies. And while there's not a lot of data in mantle cell, what data we've seen looks fairly exciting. So bispecific antibodies are engineered antibodies that combine the specificity of 2 antibodies to bind 2 different antigens. So they target, in this case, CD20 on the B cell and then CD3 on the T cell to induce T cell mediated cytotoxicity. These are off-the-shelf therapies. So unlike CAR T cell therapies, which you have to go through a process to collect these from patients, these are therapies that we can use without that wait time. Now, the glofitamab data was presented at ASH in mantle cell lymphoma. This was, again, a small number of patients, 21 patients, but showed overall an 81% overall response rate with this CD20 bispecific and a 67% CR rate, including activity in patients who had the majority of patients who'd had prior BTK inhibitor. Cytokine release was the most common toxicity, but this occurred in 58.6% of patients in all grade, but almost all of these were grade 1 to 2, with only one patient or 3.4% experiencing grade 3 to 4 CRS, and only one patient or 3.4% having ICANS, which was grade 1, so no grade 2 or higher. There were no treatment discontinuations due to toxicity. So I think the idea of bispecifics, they'll probably be more accessible than CAR T cell therapy, potentially more safe, but the duration of response and where we're going to use these remains to be seen. But I do think that they'll be incorporated into therapy in the future. The very last thing I'll touch on is the allogeneic stem cell transplant, and I mentioned this, there are places that don't have access to CAR T cell therapy, which I think is probably going to be what we prefer in patients with TP53 mutations, but this is just looking at a small subset of patients, but 43 patients with TP53 mutated mantle cell lymphoma who went on to allogeneic stem cell transplant, and showed that there was a benefit, or that allotransplant benefited these patients the same as it did the population of patients without TP53 mutations, with a 2-year PFS of 78% and a 2-year overall survival of 61%, suggesting that in these patients this is still an option for treatment. So in conclusion, chemoimmunotherapy is still the majority, the right treatment for the majority of patients at first line. The role of autologous stem cell transplant in patients who are eligible may be evolving. Rituximab maintenance, I think, still does have a role in both patients who receive and don't receive autologous stem cell transplant. We're looking at incorporating novel therapy into frontline treatment, both in combination with chemoimmunotherapy, but also in combination with just other targeted therapies. And this is likely to become part of the frontline treatment approach. BTK inhibitors are the preferred option of treatment at relapse, but the role of combination remains unclear. Hopefully the phase 3 study answers that question. But again, as BTK moves into the frontline, this may become less of a question. CAR T-cell therapy is promising, especially in these high-risk patients, but the role of sequencing still, remains to be seen. Maybe this is something that should be earlier in those high-risk patients who don't respond to other therapies, such as TP53 mutations, which there's no clear answer what to do here. There is an ongoing trial, the Bovin trial, that's looking at obinutuzumab, venetoclax, and zanubrutinib in these patients that suggested that might be potentially an effective option. Novel targeted immune therapies are exciting and I think are probably part of the future in this disease, as hopefully will have a role of risk-adapted approach. And with that, I will end. And happy to take questions.
Thank you so much, Dr. Maddocks. That was wonderful. From BR right up to allogeneic transplant. Wonderful. So some questions, Dr. Roshni?
Wonderful talk, ma'am. I just wanted to know about the SHINE trial. If we are going to use the BTK inhibitors upfront, then what will we have for relapse? And the second question is there any data like what Varsha Gandhi has done with the CLL, that we can reduce the dose of ibrutinib and give it with maybe food, and that will decrease the toxicity and maybe maintain the efficacy? This is all with respect to SHINE trial.
Yeah, so I think, the question, one of the questions when you look at the SHINE data is if you use BTK up front with BR, do you really benefit from using it up front, or do you get the same outcomes if you use BR followed by rituximab maintenance and then save the BTK inhibitor for relapse? I think based on the toxicity of the trial that it's not necessarily going to become standard in all patients. Although I do think that there probably are instances where it will get used. As far as what will be available, I mean, at this time, I think it's kind of like what's available now in patients who progress on BTK inhibitors, which we don't really have a lot of agents that have shown prolonged remission durations. Venetoclax is not approved here in the US, but there is some activity post-BTK, different chemoimmunotherapy. Although, if you've used BR, then progressing using something like RBAC doesn't make a lot of sense. CAR T-cell therapy to patients who are candidates, although again, if you have an older patient, they might not have access to that, or the toxicity might be too high. So I think all of those are options. I don't think that we have great options in that setting right now. I think that probably the future role of bispecifics is going to be in this setting. So I think that bispecifics have shown, again, not a lot of patients, but have shown pretty promising activity and are much more accessible. I also think this is something that patients who are older will be able to tolerate. So I think that that's probably going to be a treatment approach for patients who progress on BTK inhibitors, in that frontline, after BTK in the frontline setting.
What about the lower dose ibrutinib with food? De-escalating the dose, like 280, then 140, and or 560, 280, and then 140 over 3 cycles, like she has done, Varsha Gandhi.
I'm sorry, what?
You can continue, ma'am.
I was just going to say that I'm not aware of data in mantle cell specifically with doing that. would it work the same? I guess possibly. One interesting thing when you look at the differences in CLL versus mantle cell, I mean, CLL patients tend to be on BTK inhibitors a lot longer than patients with mantle cell lymphoma. So they get a lot longer durations of responses than those patients with mantle cell lymphoma. But I think looking at, combinations that reduce the amount of time on ibrutinib and then overall reduce the cost is of a lot of interest.
Thank you, ma'am.
Dr. Ankit.
Thanks for the excellent talk, ma'am. You have answered all the questions. Just your practice on doing a TP53 mutation upfront, and does the presence of such mutation impact the choice of initial therapy in your clinical practice?
That's a great question, and I think it's evolving. So we do check TP53 mutations in all of our frontline patients. It's not necessarily covered to be checked insurance-wise everywhere, but we have an internal test, and so if it doesn't get paid for some reason, our patients aren't charged. So we do check that. I try to put patients on clinical trials. For those patients who have TP53 mutations, I highly encourage clinical trials because I just don't think we have any data that there's better treatment options with any of our standard therapies. In the US right now, a BTK inhibitor is not approved for the frontline treatment of mantle cell lymphoma, but I guess that you could consider trying to get it approved in those patients who have TP53 mutations. The concern, of course, is that it's the data with the TP53, even with BTK inhibitors, they're active in the relapse setting, but they really, the durations of response aren't long. So I'm not even clear that, just that's the right answer. And we can't use combinations with all these different targeted therapies in the frontline setting. So I try to put them all on a trial. Otherwise I try to really, discuss outcomes with them and honestly, ensure that I have their kind of a plan and a backup plan.
Thank you. Dr. Verma and then Dr. Amit. Two last questions.
Nice talk, ma'am. Just wanted to know that in specific groups like pleomorphic variant and blastoid variant, do you prefer B+R in upfront setting or high dose cytarabine based, protocols like RDEP and all?
So in those patients, if it's a young patient who is a candidate for aggressive therapy, I will discuss aggressive therapy such as like a cytarabine containing regimen in consolidation with transplant. But there again, I think that's a population of patients where it's not really clear what the best answer is. So they have shorter responses. The retrospective data from the first cohort of patients I showed would suggest that while the patients with blastoid disease don't do as well with transplant or with aggressive therapies as the other population of patients, that they still benefit from a more intensive approach than a less intensive approach. But again, that was small numbers, small numbers in a retrospective fashion. So I still will offer that as an approach. I think those are, again, patients that really you want to be, or, if you have access to the trials, it's important. And I think that you want to be ready when they relapse to think about therapies like CAR T-cell.
Ma'am, in a front setting, do you see still a role of autologous transplant, or with the availability of the recent data 2022 autologous transplant? What is your take up on that?
So I think that that's a good question. And I think that if you look at even the real world outcomes of the most recent data that showed only 25% of patients treated in the US are really receiving intensive approaches in transplant, even though that's what's recommended. And there's no difference in survival, again, retrospective data. But I think that probably with therapies such as the BTK inhibitors, with CAR T, that probably in the future that there is not going to be everybody recommended for autologous stem cell transplant. I think using things like MRD might help in a select group of patients who may have gotten a good response to chemotherapy, but need to kind of get that final kick or, to put them into our MRD negative remission. but I suspect that, that auto in the current area of therapies is not necessarily for everyone.
Thank you, ma'am.
Thank you. One last question from Dr. Amit.
Well, regarding the chemoimmunotherapy regime, so what is the most preferable to you? Archa followed by R-Hydec or Archa followed by R-Hep? Or any?
So I don't think these haven't been evaluated. I think using a cytarabine containing regimen, I'll be honest, we have in the US, there's been some data on looking at BR and Hydec. So 3 cycles of BR and 3 cycles of Hydec, which is showing very promising high overall response rate, CR rates. And we have an ongoing phase 2 trial looking at that in combination with ibrutinib. So my preferred regimen is I consider that BR Hydec, or I like the RD-Hex regimen because I think, it's 4 instead of 6 cycles. The outcomes of that trial look good. And sometimes it feels like if you give patients 4 cycles, they're in a little better condition when they go to transplant. But I don't think there's a right answer here.
Thank you.
Thank you so much, Dr. Maddocks. That's all we could accommodate in the time that was available. You have been always there with us for all the educational activities for last many, many years. And thank you so much for being with us once again today. Thank you.
Thank you so much for the invite. It's always a pleasure.
We'll move on to the next lecture of the day. And it's my pleasure to introduce once again our regular faculty, Dr. Valeria Santini. She is well known to everybody who is going to listen to her today, but just to complete the formalities, she's director of the Myelodysplastic Syndrome Unit, Associate Professor of Hematology at University of Florence, Department of Experimental and Clinical Medicine, SOD Hematology, AOU Careggi, Florence, Italy. And she's going to speak to us today on what's next in myelodysplastic syndrome treatment. So over to you, Dr. Valeria.
Thank you very much for your kind invitation. I'm really happy to be here again with you and discuss the new possible future of MDS. We have some novel issues here. So these are my disclosures. And I always start with this slide. I really do like it so much because it really summarizes very clearly what we need to do. And what we need to do for an accurate diagnosis is essential for successful treatment of MDS. So the more sophisticated we become with the diagnosis, the better, and the improvement of treatment is higher. So we have novel classifications and novel prognostic system to discuss. So cytopenias are, of course, as we all know, the principal features of MDS, with anemia being present in more than 50% of patients, more rarely neutropenia, and in 1/3 of the cases, thrombocytopenia. Now, the name has changed. Now, we know that it's cytopenia, but myelodysplastic neoplasm, as they should be called now, are much more than cytopenias. They constitute a real, very complex group of disease, but we know about this a lot of preclinical data, but notwithstanding that, we cannot really always apply them directly at the bed of the patient in clinics. So the big question is how the amount of new data we are accumulating in preclinical studies and in research, how can this help us in management of MDS patients in practice? And what are the most important findings that we have encountered in the last years? Of course, we know much more about the role of inflammation in the pathogenesis of MDS. We are more and more recognizing the relevance of somatic mutations, but we also know that the role of apoptotic and survival pathways can be determinant in the outcome of MDS. We still have to understand a lot about DNA methylation and its impact on MDS natural history, And then we have a big chapter of the immune dysregulation in MDS. Role of inflammation, just starting from very basic and easy consideration. In the Italian MDS National Registry, we see that 35% of all the MDS cases that are enrolled are associated with diabetes or any endocrine and metabolic condition. Assessing these is important because we may assume that these are patients who have the possibility to have a chronic inflammation. 50% of patients with a lower risk IPSSR are the ones who have these comorbidities. And we know that comorbidities overall impact on overall survival, irrespective of how we treat the patient and whether it's a lower risk or a higher risk. 63% of MDS patients in Italian registry have anyhow significant comorbidity, inflammatory or not. So that's why we started in my lab to evaluate in a quite vast number of cases whether the inflammation we see in MDS is comparable to the inflammation of the elderly, so the so-called inflammaging of healthy elderly individuals. And this is very relevant because we have now some anti-inflammatory treatments that are available also for MDS patients, like the one that are under evaluation by the IRAK4 inhibitors or canakinumab. So we really have to evaluate which are the important differences in between healthy and MDS. You see here that for sure interleukin-6 is increased in MDS patient as well as interleukin-1 beta, whereas interleukin-18 seems to be much lower in low risk MDS patient. And these are just a very few hints I would like to give you, because we will arrive at a point in which patients will be selected for anti-inflammatory treatments. Relevance of somatic mutation is well known. I don't want to tell you anything boring. We know since more than a decade that more than 90% of MDS patients carry somatic mutation in their genes. The most frequently mutated ones are SF3B1 and TET2, differently mutated according to the subtype of MDS. You see, these are two seminal works, but we also knew since at least 10 years that leukemia-free survival is correlating inversely with the number of driver mutations. So the more mutations you have, the shorter leukemia-free survival. So the number and the type of mutation are impacting heavily on overall survival. And this is known, but we never really succeeded integrating the data of MDS mutation and survival and response to therapy. Now, this is a more recent work we just published a few months ago. It's a production of a big collaborating study, more than 2,000 cases. And in these cases, you see again the TET2 and SF3B1 mutation are the most frequent. And you see that it's confirming what I just showed you. But what has been done here is that overall survival has been correlated to all pathogenic lesions. So all the genomic lesion mutations or cytogenetic abnormalities do correlate with overall survival. And completely agnostic of the morphology that I just showed you in the first slide, here is a proposal of a new classification of MDS based only on genomic and genetic alteration, both, as I mentioned, mutation, DNA mutation, and chromosomal aberrations. This classification allows a stratification in different groups correlating with overall survival. So even if we consider only genetic alteration, we may stratify and predict outcome of patients. But this is the great news. Finally, the International Working Group on MDS for the molecular classification of MDS has developed the IPSS molecular. The IPSS molecular is based on the analysis of almost 3,000 cases of MDS gathered from all over the world. In 41% of this group of patients, there were cytogenetic alteration, but more than 90% of the patients did show a DNA mutation. And the development of the model was possible because there were the possibility to, on the basis of, we will see some variables and the somatic mutation, to stratify into 6 categories, prognostic categories, that we really stratify the patient very clearly in different groups. Now, it's a continuous risk score and takes into account the hemoglobin level, the number of platelets, and the bone marrow blast, exactly as IPSS are. It does not take into account neutrophil counts because it doesn't seem to be a relevant and significant variable, but the system is also including the cytogenetic IPSS category and 22 features that are derived by the presence of mutation in 21 predictive genes plus 17 additional genes that provide an extra feature. So it's a rather complex model, but it's allowing a continuous risk score with a patient-specific evaluation of risk of evolution. So again, leukemia-free survival is the endpoint that is considered here. So while IPSS-M was published on June 12, June 22, so the publication of the new WHO classification for MDS. To my great happiness, this classification seems to be easier than the previous one. And as a matter of fact, the MDS are defined in 2 categories, the ones with genetic abnormalities, so and the one that are still morphology defined. So the genetic abnormalities being del5q and SF3B1, the mutation of SF3B1, or eliminating in a way the definition of MDS with ring sideroblast, and then the MDS with biallelic TP53 mutation. So this is just not so straightforward as it may seem, but it's very interesting that now we have 3 different categories of MDS defined only by genetic abnormalities. Then we still have the morphological defining, especially the ones who have increased blast. Instead of excess blast, now we talk about increased blast, 5 to 9% and 10 to 19. And then the new categories that have been included are the ones with hypoplastic marrow, so MDS with poor marrow cellularity, MDS with fibrosis, I think very important because we know that this category of patient has a poor outcome, and then the MDS with low blast count, so-called MDS-LB. So actually, a completely new picture respect to the past. We have implications here, also because of the definition of MDS with the increased blast that may include some cases, especially also with the biallelic TP53 mutation, and include and merge with AML. And the discussion is open and will be I think, a matter of discussion and lively discussion in the next few months. The childhood myelodysplastic syndrome have also been reorganized, whereas I want to stress the fact that CMML, chronic myelomonocytic leukemia, has been also redefined with a lower number of absolute monocytes, 500 per microliter, and with a percentage of monocytes respect to white blood cell that is still 10%. Now, what is also very, very interesting in the WHO 2022 classification is that we have a scalable model of germline predisposition to myeloid neoplasm. So, as you may see, respect to the WHO 2016, we have an ampler number of mutations that are recognized as predisposing to MDS in particular. And what is quite important, and I want really to remind you, is that we do not know yet all the predisposing conditions, genetic conditions, that could be interesting for MDS. And this has clear implication for the choice of therapy, for the choice of donor in case of transplant, and for the evaluation of the outcome. In fact, probably Professor Niemeyer will discuss this, but we do not know exactly what is the border between adult and infant or children MDS. We do not know the age of manifestation of MDS in the cases of germline predisposition. We know that DDX41 mutation is also apparent in elderly, in patients who are diagnosed in advanced age with MDS, whereas there are all these other alterations that may be ranging from infant to adult life. And we know also that the incidence of MDS increases with age, but this group of patients reaching 60 and below 60 are a group of patients that has never been explored thoroughly. And if you exclude the patients who have received radiotherapy or chemotherapy, we still have to understand why these patients do get these diseases. Germline predisposition can be present also when you do not have any alarm in presence of syndromic manifestation. And what we know is that in adults, we see a germline predisposition in less than 20% of cases, 13% in a recent work of patients aged less than 45 years and receiving a stem cell transplant. There are no studies actually available on predisposition performed only on the basis of age and age at diagnosis. That's why we wanted to evaluate whether in a group of patients that for Italian standard is clearly younger than usual, so lower than 60 years, could have and could show predisposing alteration. And for this, we evaluated by whole exome sequencing and target NGS the presence of genetic alteration. These are the results. I don't want to go into details, just to tell you that in this group of 31 patients, we identified almost 55% of cases carrying predisposing alteration, genetic alteration. So in 12 out of 17 patients, we had high confidence germline MDS variant. So we were sure that this patient had a predisposing genetic alteration. This is extremely important given the fact that we never realized that it could have been so frequent. And once again, I want to reiterate the fact that the choice of the donor for this patient should be very carefully performed, because this patient cannot really receive a marrow from a familiar donor without previous evaluation of the possible predisposing condition of the donor himself or herself. So having said so, we go on. And what I would like to discuss is whether recent observation can drive really the management of MDS patient in practice. Everything could be different from what we do and might be different. And should we then, after what I just said, base our therapy and our choice of therapy only on individual molecular pattern? So we have just discussed this, and these are the therapies that are available, like EPO, luspatercept, lenalidomide, and hypomethylating agents. Luspatercept and lenalidomide based on genetic features of the patients. And then all the other treatments are under evaluation and may be actually targeting specific pathways. So I want to discuss some of these therapy. The first one being imetelstat. So imetelstat is a competitive inhibitor of telomerase activity. Telomerase activity is increased significantly in MDS patients. And these patients do have an increase in proliferation related to decrease of telomeres. Now, this inhibitor has been proposed for treatment of patients with lower risk MDS, refractory or not eligible for treatment with ESAs, for erythropoietic stimulating agents, and with naive, let's say, without a history of treatment with lenalidomide and hypomethylating agents. This study had as an endpoint the achievement of transfusion independence longer than 8 weeks. You see that 42% of patients achieved this objective, and many of them achieved also an improvement in hematopoietic, in erythroid hematopoietic activity. Some of the patients who achieved transfusion independence had a very long transfusion independence, longer than 1 year in almost 1/3 of cases. So it's really a significant change. What is very interesting of this study that is now really stressing the fact that this can be a disease-modifying agent is the fact that when you evaluate the pharmacodynamic effect of this treatment, meaning a reduction of more than 50% of hTERT expression from baseline, you see that the patient who achieved this pharmacodynamic effect have a higher probability to have to get rid of transfusion, to have transfusion independence, not only, but this transfusion independence is longer, has a longer duration, always related to the pharmacodynamic effect. So reducing hTERT correlates with response and with duration of response. But even if you do not reach complete transfusion independence, this pharmacodynamic effect indicates a higher susceptibility and then a more significant decrease in a number of transfusions. So we have a very interesting new approach with telomerase inhibitor, but we also have other attempts to attack the dysplastic clone in a different way. So we have here the HIF pathway depicted. HIF alpha is stimulated by hypoxia, and by migrating to the nucleus binds to gene transcription factors, and the gene transcription is effective, stimulating erythropoiesis by increase of EPO, increase of iron transport to the bone marrow, increased iron absorption, and of course, decrease of hepcidin levels. Now, usually, HIF alpha is very rapidly degraded, so it is stimulated by hypoxia, but then immediately after having done its job, let's say, is degraded. Roxadustat is a molecule that is stabilized HIF alpha just by inhibiting prolyl hydroxylase enzyme that are degrading it. This is why it seemed to be a very interesting molecule that has been approved for treatment of anemia in chronic renal insufficiency. And a few weeks ago, the first open-label lead-in study has been published. In this study, the patients treated were lower risk transfusion-dependent patients or anemic patients who did not have deletion 5q, had a low transfusion burden in between 1 to 4 red blood cell in 8 weeks, did not receive treatment with ESAs, and had a serum EPO level in between 200 and 400 units liter. Of course, the primary endpoint was to verify how many patients achieved significant transfusion independence for more than 8 weeks. And also, in analogy to what we saw for the other studies, more than 50% reduction in transfusion needs. 3 doses were available, were possible, with patients who could escalate the dose after 8 weeks of treatment. Now, these are the results. You see that overall, 38% of the treated patients, indeed a small number, but quite interesting results, were transfusion independent after treatment. And among these, the patient with ring sideroblast responded in 23% of the cases, whereas the patient without ring sideroblast responded in a higher percentage of cases. The baseline EPO did not really impact on response. So we have here a complete different approach from previous ones. This is an oral drug. The second phase of the study, that is a randomized, double-blind, placebo-controlled study with much higher number of patients, has just been or is going to be concluded in these days. And we will see whether the efficacy of this drug and the safety of this drug can give another option to our patients with lower risk MDS. Now, treating and discussing targetable molecular alteration, of course, we have to remind the fact that we have ivosidenib, a molecule that blocks and actually targets directly mutant IDH1. This study has been presented at ASH and updated later, and it's a European study. These are the French data that have been presented, and you see that the patients here are divided into 3 groups. They all have mutation in IDH1, but there can be higher risk patients who failed to respond to azacitidine after 6 cycles, or patients with higher risk MDS but mild cytopenias who could be treated with the monotherapy ivosidenib without fear of rapid progression of disease, but also lower risk MDS patient with anemia failing EPO, whereas cohort A would receive ivosidenib only after 6 cycles of azacitidine in absence of response. So in all cases, ivosidenib was active because there was an overall response in 69% of the cases. I just again want to stress that the patients here are elderly, 76-year-old, and that if you treat patients in first line with ivosidenib, the response was really striking, 91%. So I think this is a possible way to go. Again, an oral drug for elderly patients that can be treated easily or in a more let's say, friendly way at home would be possible. Similar design of the study is that with inazidenib targeting mutant IDH2. Okay, IDH1 and IDH2 are quite rare in MDS, 5 to 10%. Still, if we could obtain in this small subgroup of patients a durable result with this drug would be very interesting. And this is why I am presenting you this data. Here with enazidenib, we have a slightly lower overall response rate, 42%. In patient refractory to hypomethylating agents, 1/4 of the cases were successful, whereas in first line, we have here 56% of response. Now, I talked about interesting and challenging design of studies, but given the last results we had with new drugs, should we completely rethink study designs and clinical endpoints? Because I want just to depict some of the agents that we were really expecting to have a great activity in MDS. and were failing phase 3 studies. For instance, APR-246, defined as a p53 reactivator, even if its mechanism of action is not exactly so. It was evaluated in 2 parallel studies, one in France and one in the US, in combination with azacitidine. And it was, of course, evaluated only in patients with high-risk MDS and mutated TP53. And the overall response rate in both studies was really high. 62% in the French study and more than 70% in the American study, with a very high proportion of patients achieving CR. So on the basis of this data, a phase 3 study was designed, but the phase 3 study did not meet the primary endpoint of CR rate. So what was expected to be confirmed was not confirmed. So in these 154 patients, CR rate of the combination was 33% versus the CR rate of azacitidine alone, that was 22.4%, meaning that this was not significant, and therefore the study was not successful, with the overall response rate and overall survival that were not significantly different. So this is something we should ask ourselves why. I mean, the data of the phase 2 were clearly positive. So maybe the endpoint chosen for the phase 3, merely the CR rate, was not the ideal one. Maybe we should really rethink and discuss more how to design study in this group of patients, because the same was true in part for patients treated with pevonedistat. Now, if you recall, the results of the phase 2 of pevonedistat in association with azacitidine in patients with high-risk MDS or treated treated in comparison with azacitidine alone were very good. So the overall response rate was 79% for the combination versus 57% for azacitidine alone, with a median overall survival of the combination of more than 20 months. That's why, again, randomized phase 3 study, pevos plus azacitidine versus azacitidine, and the patient included were not only high-risk MDS, but also CMML and AML with 20-30% of blast. The primary endpoint here was chosen to be event-free survival and transformation to AML in cases of high-risk MDS or CMML. Overall survival was only a secondary endpoint. So what happened is that there was no event-free survival advantage in the group of patients treated with azacitidine and pevonedistat. Median event-free survival was 17 versus 15. Therefore, we have to ask ourselves again whether this was not chosen properly and what was possibly gone wrong, given, again, the very high and good results of the phase 2. Now, if you then look a little bit better to the patient who had received more than 3 and even better, more than 6 cycles of therapy, you see that here, especially in the 6 cycles on your right, you see that the patient receiving the combination had an overall survival of 27 months versus 22 of azacitidine, seemingly having a real significant increase of overall survival. So I think that the next few months will be discussing the design of new studies and new agents. And I will just want to dip into this discussion at present, touching upon the endpoints of the study for lower risk MDS. Should we include, instead of response of transfusion independence, also overall survival, and even more important, so quality of life? So I recently revised the study, all the study treating patients with lower risk MDS with lenalidomide, both non-del(5q) and del(5q). And what was clear was that overall survival correlated strongly with transfusion independence. So response to lenalidomide was correlating with overall survival. That's a thing that we never take into account in lower risk MDS, because of course it takes a long time to see a significant difference in patients who live several years in comparison to higher risk MDS. But this is a relevant point, as well as the exact scoring of quality of life during treatment. So in this analysis that was carried out in in a group of patients treated with non-DELFA-2 treated with lenalidomide, I could show that the quality of life was increasingly better in patients treated with lenalidomide in some items and in some issues. So this is what we should, I think, implement more and more in the design of our studies and also in everyday management of our patients. Finally, we are still discussing about hypomethylating agents. As you may have noticed in the previous slide, I always speak about combination of new and novel agents with hypomethylating agents. Now, are they still so important to be the backbone of therapies? Now, we know that the modulation of methylation is paralleling the individual response to HMA therapies. We could never show exactly the correlation between CpG island methylation and hypomethylation, actually, and response to azacitidine. But as you may see from these unpublished results of ours that we are completing, there is a pattern of hypomethylation that changes in between baseline, enter, and post-therapy at response, post-therapy and relapse, diagnosis versus relapse, meaning that, first of all, the differentially methylated regions are not always in the promoter regions of the genes, but may be intergenic and the enhancer. And not only these, but they are indeed different in diagnosis versus relapse. So it doesn't mean that methylation goes up again when the patient is relapsing, but it does mean that the methylated regions are different. So we are still in the need of discussing what is the importance of methylation, also because we have now new drugs, or let's say new formulation of old drugs like the oral hypomethylating agents, Aztec 727, that is decitabine plus sidazuridine that stabilize the drug. And you see that in the patients treated with this oral compound, you have a very high percentage of response. And of course, median overall survival that is very significantly prolonged respect to the historical controls. We also published the data of an old study of ours with CC486, that is the oral azacitidine in combination with, in patient with lower risk MDS and thrombocytopenia. Now, these patients are a particular subset of lower risk MDS that frequently evolve into higher risk, that have some features indeed of higher risk MDS, in which the treatment was anyhow able to increase the number of platelets, as you see here on your right, and also induce transfusion independence. So it's a very interesting approach, but as a matter of fact, it's not devoid of myelosuppression, so it should be very well considered for use in lower risk MDS. So what is near future for the combinations in therapy of higher risk MDS? Maybe we will combine hypomethylating agents with new investigational agents. We are already combining hypomethylating agents with two novel agents. And maybe in the future, we will completely get rid of the hypomethylating agents and just use combination of novel agents much more effective than the hypomethylating ones. Now, I want to conclude my talk by touching upon the immune-based therapy that have recently been finding a new let's say, a new interest in MDS. Now, these are the immune therapies that have been proposed in the past with some effect, actually, given by the checkpoint inhibitors, indeed, but also quite a number of side effects, so very many issues in terms of safety and not a very prolonged efficacy. Now, there are novel approaches of immune-based pathways that are magrolimab, so the antibody targeting CD47, CA4948 targeting IRAK4, and sabatolimab targeting the TIM3 antigen. So let's start from magrolimab. Magrolimab is targeting CD47, as I mentioned, that is expressed on cells that may be like leukemic or dysplastic blast. And this is CD34 antigen is blocking phagocytosis. It's a sort of do not eat me signal that impedes and blocks macrophage from eating, let's say, from phagocyting the leukemic cells. Now, if we block this CD47, we may restore phagocytosis and then eliminate leukemic cells and dysplastic cells. That's why magrolimab was used in combination in higher risk MDS patients, de novo. So you have an escalating and let's say a priming dose of magrolimab followed by the full dose. The antibody is given intravenously with a standard dose of a scheme of azacitidine. The primary objective of the phase 1 study, of course, was safety and also efficacy. You see that these are the updated results recently presented at EHA. So overall response rate in all patients was almost 75%, with patients with TP53 mutation responding in 68% of cases. And again, high proportion of patients with CR rate. And many of these patients treated with magrolimab could undergo transplant because of the improvement of the general conditions. Now, magrolimab has a side effect that is inducing anemia, hemolytic anemia, because of the phagocytosis of red blood cells expressing CD47. But these are the results. You see that even for patients with TP53 mutation, overall survival is really significantly improved if treated with magrolimab and azacitidine. Patients overall have a very long overall survival when treated with the combination. The phase 3 study is still accruing patients, and you see it's comparing in a blind randomization magrolimab plus azacitidine plus to placebo plus azacitidine. And again, we will be very interested and eager to see the results of this ample study. You see a huge number of patients. Still a different approach is the one of sabatolimab. Sabatolimab is a monoclonal antibody targeting TIM3. Now, TIM3 is an immune myeloid regulator and is expressed on T helper cells, exhausted T helper cells that infiltrate neoplasia and are near to leukemia cells, and at the same time is expressed on leukemic cells and dysplastic blast. Now, sabatolimab targeting the TIM3 expressed on lymphocytes would get rid of the lymphocytes who are exhausted and do not have immune function and increase instead the immune function of T cells against the dysplasia and leukemia. whereas targeting TIM3 expressed on leukemic cells and inhibiting TIM3 and galectin-9 self-renewal of cells can be increasing the efficacy of azacitidine. This is the scheme of the phase 1 study that was combining the hypomethylating agent decitabine and azacitidine to different schemens dose of sabatolimab, either twice a month, 240 or 400 milligrams IV sabatolimab, or once a month, 800 milligrams sabatolimab. The primary endpoint being here, of course, safety, and secondary, the efficacy. So what was seen is that patient with high risk and very high risk MDS had a very good response. The overall response rate was 57% around, but the duration of response was pretty long, more than 17 months, with progression-free survival exceeding 50% of patients at 1 year. So it seems that this treatment endures and renders really stabilize the best responses in MDS patients. One thing to remind as well is the fact that TP53 mutated patients were also responsive to this treatment. And this is why sabatolimab studies are ongoing with different schemes. So we have Stimulus MDS1 that is evaluating CR rate and progression-free survival, another study that have a different endpoints like overall survival, and again, one triplet with sabatolimab, venetoclax, and azacitidine. And we are looking forward to see the results of all these studies to implement our armamentarium of treatment for higher risk MDS. This is another interesting drug that is the inhibitor of IRAK4. This is emavusertib. This is a first-in-class suppressor of toll-like receptor pathway that inhibits IRAK4. And you see that very few patients have been treated, but these patients seem to have a good proportion of CR rate and good response. So again, this is something that we are really looking forward in the next few months. Now, the prima donna of treatment of high-risk MDS is indeed venetoclax. While we wait for the result of the randomized study, venetoclax plus azacitidine versus azacitidine, the Verona trial, I can show you some of the data that indeed in higher risk induced a very good response rate. Overall, 80% of patients responded with 40% of CR rate. This is, of course, a phase 1b study. The overall survival was extremely good with more than 2 years overall survival, 28 months. And with survival estimates at 1 year exceeding 75% of the patients. Now, as well as for what we have shown previously with magrolimab, the most interesting feature here is that 23% of the patients treated successfully could in fact undergo allogeneic stem cell transplant. And this is a very good, because of the increasingly better general conditions. To confirm this data are the data on real life provided and published and presented by the Moffitt Cancer Center and the Anderson Experience, in which overall response rate was really similar to the one I showed you in phase 1 study, 77%, and an overall response rate that could be present both in patient with naive MDS, so untreated first line, or relapsed refractory. So I think that this is really something we will see again. The study has closed, so we are looking forward to the final results. And I want also to stress the fact that now we probably are in the era of total oral therapy. Oral decitabine has been, as you have just seen in my slides, have been compared to IV decitabine, is exactly equivalent. And these few patients treated with oral decitabine and venetoclax had an overall response rate of 100%, meaning that we can really plan and design studies or treat every day our patient with total oral therapy. Of course, not devoid of myelosuppression. These are patients who have to be followed up seriously and frequently because of the myelosuppressive effect of both drugs, but can be much, for their quality of life, much better managed. Finally, age has always been a limit to include MDS patients in transplant programs. But these data show that even if you have elderly patients with an age above 65, the results of present approach to stem cell transplant are no longer a problem. And that's another point for our patients, another option. So we will have open issue to discuss. And if you are so kind to let me talk again in the future, we will decide how to employ and how to use the predictive genomic signature of patients to decide for transplant. What is the best pre-transplant therapy? We still don't know whether we have to use hypomethylating agents and venetoclax or CPX or hypomethylating agents and, for instance, sabatolimab, or maintenance or magrolimab, or maintenance after hematopoietic stem cell transplant, oral azacitidine versus sabatolimab. These are all issues that are still open. We wait for more evidence from real life, but also from the study that I just presented to you. And all these data and variable, how can we manage them? There was a very interesting session at EHA discussing artificial intelligence support to our choices of therapy, but also we could implement artificial intelligence to improve diagnosis, prognosis, and indeed support our choice of treatment. I think I will stop here, and I really wish to thank you for your attention, and I will be happy to take any question.
Thank you so much, Dr. Valeria. That was fantastic. We enjoyed listening to you today. Dr. Roshni has a question for you.
Good evening, ma'am. The first question is related to TP53. Are all TP53 mutations bad, or is it monoallelic versus biallelic, which will upstage a patient from low risk to high risk?
Now, TP53 mutations are usually biallelic when accompanying complex karyotype. Then the patient, by definition, with complex karyotype and cytogenetic and cytopenias are high risk. So usually, biallelic TP53 mutation are characterizing higher risk MDS patient. Then when we talk about generally TP53 mutation, of course, we have a general definition. The mutation that do really impact on outcome are the biallelic one. And a surrogate for evaluating biallelic ones is indeed variant allele frequency exceeding 50%. It's not always possible to really measure the biallelic nature of the mutation.
And the second question is, in the era of NGS, does bone marrow fibrosis matter?
Indeed, it does. Indeed, it does, because patients treated with azacitidine, for instance, and having a fibrotic marrow do have a scarce response. And indeed, fibrosis is pointing independently of mutation, is pointing for a worse outcome. This is why it was implemented in the new WHO 2022 classification.
And the third question is, in all the trials, what is the dose of when used?
Now, that's a very important question. Now, the dose of venetoclax used in MDS is 400 milligrams. It's not possible, though, to keep the 28 days scheme and not even the 21. So the ideal is 14 days with a great attention to possible myelosuppression. And of course, if you give posaconazole, you have to lower the dose of venetoclax to 100 milligrams, at least.
So has that been now standard of care in trials to use a lower dose with posaconazole?
We do use posaconazole in prophylaxis for patients who have lower neutrophil lower than 500 microliters. Otherwise, we do not use it.
Thank you, ma'am.
Thank you, Dr. Chirag.
Yes, thank you. Now, this question related to azacitidine and venetoclax. In AML, it is very widely used. So there is a awareness of this regimen. Now, can we start using this in MDS, and how any different experience compared to AML?
Now, as I showed you, well, in Europe, we don't use it outside clinical trials. And we still have to see the data of the Verona trial, the randomized trial, to be comfortable in using it in MDS. As a matter of fact, in my experience, azacitidine plus venetoclax in MDS is more toxic in terms of myelosuppression with respect to azacitidine venetoclax in AML. So I think that we should take more attention and be more careful in the use of this combination in MDS. For sure, it's a potent combination. It is very effective, but we will have to select the patients with MDS who could really be treated like this, because they would be the fittest, probably the ones with less comorbidities, and youngest, most probably.
So I think that's very important. Thank you. We will have to be very careful, unlike AML in MDS. Second question is related to the inflammation. You mentioned some role, and that reminds me of some early data of cyclosporine plus thalidomide. There was a trial published in Blood a long time ago with very good results, but then there were no other studies. So is there is still on the card use of cyclosporine somewhere in the low risk MDS with lenalidomide or thalidomide or any other agent?
That's a good point. We do not have at present such studies, so there are not new studies evaluating the combination of cyclosporine and len or thalidomide. But I can tell you that, in fact, cyclosporine, especially in patients who cannot receive ITG, is very effective in patients with hypocellular MDS, and I do use it with success. So the story of inflammation, actually, it's an old story. We knew since decades that MDS patients are inflammated, let's say, but we never really found a way to treat safely and with efficacy this kind of problem in MDS. This is why I think we have to distinguish the inflammation typical of aging from the inflammation of MDS and target especially the cytokines and the alteration that characterize MDS.
Great. Thank you, Matt.
Thank you. Dr. Cecil?
I just was wondering about the inflammation in MDS. If we are able to assess the inflammatory markers, IL-6, IL-18 and things like that, and you find it's quite high, can we use that as a marker to start, let's say, NSAIDs or COXIBs or steroids as an anti-inflammatory?
I didn't hear you well. So you mean if we find that the cytokines are overexpressed and overproduced, correct, we can target these specific cytokines with inhibitors? Is that the question? Yes, indeed. That's the point. That's why I would like to really verify in a consolidated manner which are the cytokines that can be targeted specifically to obtain an improvement in hematopoiesis.
What about using general anti-inflammatory, broad spectrum anti-inflammatory, like oxybs or steroids?
Of course, because you know that sometimes steroids can be good enough to increase hematopoiesis, but again, they are very generic. Even if someone I heard a few days ago said that in fact, in some cases, corticosteroids should be considered as target therapies, because in fact it's true, they are anti-inflammatory and they can obtain, can give good results, yeah. In some cases, then you have to take into account that there are also autoimmune manifestation accompanying MDS, so that if you target them with immunosuppressive drugs, you obtain both results. And of course, autoimmune diseases are quite important to consider as well.
Thank you.
Thank you.
Sorry, Dr. Sanjeev.
Hello, good evening, ma'am. Thanks for the excellent update. So my question was about the anti-CD47 you showed about the magrolimab. So do you see a role of screening the myeloid blast by doing immunophenotyping for CD47, or it can be uniformly used even without immunophenotyping for CD47?
I do think that all the blasts and the immature cells do express CD47. So I don't think that there are data supporting the immunophenotyping or supporting the fact that if you have more expression, the drug is more active. Not as far as I know, but again, the data, the translational data of the study are not available yet.
Okay, thank you, ma'am.
Sushil.
Thanks for the excellent talk, Dr. Valeria. There was just a few questions I had. The MDSF entity is there an overlap with MDS-MPN, or has MDS-MPN been removed from the classification?
No. Now, the MDS-MPN, I just showed quickly, but the MDS-MPN have been recognized as a separate entity, and I just stressed the classification of CMML. In fact, what was eliminated and defined in a different way is the atypical CML that is now called MDS-MPN with neutrophilia. And then we have MDS-MPN with ring sideroblast.
Okay, because the ICC classification that we had looked into some time back was still, so I mean, where would you stand in that?
Yeah, you know, it's different. And now we have two classifications that came out at the same time, the ICC and the WHO. So I just presented one of the two. I think we will have to get accustomed to the two classifications and discuss exactly what to do with it, because they're a little bit different. In the ICC, I didn't, for the sake of time, I didn't go into discussion. There is also the discussion of distinguishing MDS and AML. And again, I fear that putting all together as it could be the danger, then it's going to be confusing. It is true that some MDS and some AML are the same, especially hypoblastic AML, but confusing the two will bring us a little bit back when we were putting all together and treating in the same manner. So this is just, I mean, it's been published not even 10 days ago. So I will just like to see how we will discuss. I already discussed with some of the author of the WHO and ICC several of the points I did not agree with, because it's very difficult, and some of the border among diseases are quite difficult to set. So I suppose that we all have to say what we think. It's not an easy disease. It's a very difficult disease to diagnose, to classify. And the more we know about molecular features, the more we get in trouble, I think. So you are perfectly right.
Thank you. I don't see any other raised hand sign. Are there any other questions for Dr. Valeria from anybody? None. Then before I hand over the dais to Dr. Manoj for official thanks, I would like to thank Dr. Valeria on behalf of Mumbai Hematology Group immensely.
Professor Agarwal, thanks a lot.
Immensely. Over to Dr. Manoj.
Thank you so very much, Dr. Valeria Santini. We can't be thankful to you enough. The countries that are listening to you today is, apart from India, Ghana, Egypt, Indonesia, Lithuania, Malaysia, Louisiana, Sri Lanka, India, Singapore, Bangladesh, Myanmar, Ethiopia, Australia, Sri Lanka. So I need to thank all the delegates who have attended.
Unbelievable.
Truly incredible web series, and thank you so very much, ma'am, for
great job of you. Thank you very much for including me in your program.
Thank you, ma'am. And I also want to thank other two experts who spoke today, Dr. Cami Maddocks and Dr. Jan Zaucha. Both of them were wonderful too. And all the expert discussions today, Dr. S.P. Verma, Dr. Amit Kumar, Dr. Rajiv Dey, Dr. Chirag Shah, Dr. Ankit Jitani, Dr. Roshni Pandey, Dr. Kunal Goyal, Dr. Tejeshwani, Dr. Shusil Selvarajan, Dr. Sadashivudu, Dr. Cecil Ross, Dr. Sanjeev Gupta, Dr. Shilpa Prabhu, Dr. Radhika, Dr. Akanksha Garg, and Dr. Gunjan. Please remember to log in again tomorrow at 6:25. We have again another 3 experts speaking to us. Professor Dr. David Rees from London, Dr. Shahrani Kudansi from London, and Dr. Haifa Katurian. And thanks to none other than Professor Dr. M.B. Agarwal, sir, teacher of teachers, inspiration to all of us. I just wanted to tell you, ma'am, that he just finished 250 plus educational web series in last 2 years. So that's what is Professor Dr. M.B. Agarwal for all of us and many other countries. Thank you so very much, sir. All of you have a wonderful evening and good night.